Ladies and gentlemen, the symposium will begin in 3 minutes. Please take your seats and be ready to start. Thank you for your cooperation. Ladies and gentlemen, the symposium will begin in 1 minute. Please take your seats and be ready to start. Thank you for your cooperation. Good morning, ladies and gentlemen. Welcome to the International Medical AI Symposium 2024, held by National Defense Medical Center and Tri-Service General Hospital. This symposium focuses on the transformative role of artificial intelligence in clinical medicine. Today, we'll explore how AI is shaping the present and future of healthcare. Through these sessions, we aim to foster collaboration and innovation in the clinical AI. Now, let's begin the first session of the day. It's my pleasure to welcome our first speaker, Professor Hudson Lee. And moderating this session will be Professor Wenyu Lin. Please join me in giving a big applause.
Okay, good morning, gentlemen, our esteemed colleagues and distinguished guests. And welcome to the exciting Medical AI conference. And I'm happy to be here with all of you and chair these sections. And it's my great honor, our distinguished speaker, Professor Hudson Lee. So Professor is online, right? Yes, okay. Let me introduce the Professor Lee briefly. Professor Hudson Lee is a globally recognized cardiologist from South Korea, from the Seoul National University, and completed his specialized training in cardiology at the prestigious Seoul National University Hospital. Currently, he serves as the Chief Medical Officer at Medical AI, a pioneering company dedicated to advance the integration of AI and into the medical practice. He also leads as the director of the Artificial Intelligence and Big Data Research Center at Shizhong Medical Institute. Professor Lee's research is focused on AI revolution. His contribution included the development of AI-driven ECG model for many cardiac disease detection and predict the future outcome. Unfortunately, Professor Lee is unable to join us in person today, but he has prepared a 15 minutes pre-recorded video presentation. And today he will give us a talk with the title of The Present and the Future of AI ECG, Hype or Hopes. After the video, and we will have a 10 minutes discussion online with Professor Lee. So let's welcome Professor Lee and watch the video.
Hello everyone. Thank you for having me today. I apologize for greeting you from afar. I'm currently in Washington, D.C., so I'm joining you remotely. My name is Seung Lee. I'm affiliated with Sejong Hospital in South Korea and serve as the Chief Medical Officer of a startup company called Medical AI. Title of my presentation today is The Present and Future of AI ECG, Hype or Hop. So I know there will be many distinguished speakers following me, so please feel free to relax and enjoy this session. Now, let me tell you about what I do. Since the advent of AI, there has been ongoing debate about whether it will be a risk or a major benefit to us. One thing we know for sure, AI will not replace innovators like us. So how should we approach this hype or hop of AI? Both Sejong Hospital and Medical AI, which is company's name, are deeply invested in AI ECG technology with substantial data, a supercomputer, and many collaborative partners. We are committed to advancing this field. Let me explain. AI has progressed at an astounding rate in just a few years. Not long ago, we were impressed by AI distinguishing between cats and dogs. Now in the field of image analysis or photo analysis, we're witnessing rapid changes. I'm sure you are all familiar with this development. In many ways, ECGs could be seen as images too, or pictures too. While they are technically 12-lead data recorded at 500 Hz over 10 seconds, they function as a kind of image that AI can interpret. So even the latest Brown Bar textbook of cardiology include a section on AI in cardiovascular medicine, quite a significant milestone. Our journey began with two groundbreaking studies led by Mayo Clinic team, including Jackie. The first study used retrospective data to analyze patients with sinus rhythm and predict their risk of developing atrial fibrillation within a month. This was published in The Lancet. And the second study matched echocardiogram-derived ejection fraction with ECGs to create a model that predicts low ejection fraction or left ventricular systolic dysfunction from ECG data. Interestingly, in the bottom right corner of the graph, you see a red line representing false positive patient who, while initially healthy, eventually develop heart failure over time. This shows us that AI might capture certain subclinical or preclinical aspects. This sparked a series of similar studies, including our own. The logic behind these studies is straightforward. Even data that seems not to impact decision making can be valuable when it's high dimensional, well labeled, and paired with AI's computing power and a degree of trust in AI technology. Such data can serve as a digital biomarker influencing clinical decisions. So digital biomarker, especially with AI-enabled ECG, have key advantages. ECG analysis is cost-effective, simple, and rapid, with an accuracy of approximately 90%, which is quite high. Beyond the standard toilet ECG, other devices like smartwatches and portable ECG devices can be used for continuous monitoring. AI ECG can assist not only in diagnostic support but also in treatment monitoring and predicting prognosis, depending on how it's applied. So this versatility means AI ECG could be used for conditions like LVSD, low ejection fraction, myocardial infarction, including non-STEMI, AFib prediction, and much more. Now, let me share some of what my team and I have been working on. The fundamental AI ECG model developed has been completed. This model targets heart failure or low ejection fraction. We've demonstrated strong performance with both 12-lead and single-lead ECGs as well. One fascinating discovery is that we can predict HFpEF or heart failure with preserved ejection fraction with high accuracy. Moreover, patients flagged as false positives were later diagnosed with HFpEF, showing AI's ability to capture latent conditions. We've developed additional models, including one to predict aortic stenosis as well, and others to diagnose anemia. And we have a lot of models: hypothyroidism, acute kidney injury, and left ventricular hypertrophy, all using only ECG data. Another achievement I'm particularly proud of is our generating technology, where we can generate the remaining leads from just 2 leads, leads 1 and 2, and we make other 10 leads. This approach is more accurate than using a 2-lead model alone and demonstrate scalabilities for single-lead and 2-lead portable devices. Using this generating technique, we conducted several studies. For example, we validated myocardial infarction predictions by generating chest lead V1 to 6 from limb leads, and it worked well for detecting both STEMI and non-STEMI as well. With growing confidence, we tried diagnosing heart failure using smartwatches in a study with around 700 patients. And we found high diagnostic accuracy on both Apple Watch and Samsung Galaxy Watch as well. And we've now explored validation through other approaches as well. We validated our models in patients with PPC and peripartum cardiomyopathy, and it performed accurately. AUC of 0.979. And we also tested it on atrial fibrillation with rapid ventricular response, AFib with RVL, where EF is crucial for rate control, and particularly in setting without primary care or echo specialist. The model worked well here too. And most recently, we conducted a prospective study with 1,600 patients performing echocardiograms with 6-lead portable ECG device from LiveCore. But the 6-lead and 12 AI-enabled ECG models demonstrated strong predictive power for low ejection fraction. This is something I presented last week at TCT among patients with LBBB, left bundle branch block. There are both those with and without heart failure. So using engineering-based models, we develop a model that effectively differentiate these groups using only ECG data. Here, we track the natural course of AI score in STEMI patient. The AI ECG score peaks sharply just before the procedure, then gradually decrease, much like troponin levels. These could potentially serve as a marker for treatment monitoring or prognosis. Not bad, right? This slide shows the result from approximately prospectively collected 8,000 chest pain patients who visited a major hospital in South Korea. AI ECG performed better than troponin and outperformed other clinicians' predictions in EM. So even when troponin isn't elevated, AI ECG can help triage patients, allowing effective referral to cardiologist. On the other side, one of AI's limitation is its black box nature, where we cannot fully understand its decision-making process. Expecting people to trust AI's results without transparency is challenging. That's where explainability or transparency comes in. It's about showing how the AI model makes decisions. This is ethnically important and provides accountability. So when we explain our model, the table on the left highlights its sensitivity to traditional medical knowledge we are familiar with, such as LBBB, RBBB, atrial fibrillation, and ST changes. On the right, we illustrate how the model identifies heterogeneous subgroups within conditions. Even if two patients have the same condition, low ejection fraction, AI distinguish between, for example, ischemic cardiomyopathy and non-ischemic cardiomyopathy-like profiles. These are essential points for discussion. I currently live in United States, and here are some collaborators: UCLA, Columbia, Thomas Jefferson, Houston, Illinois, Basel, Barcelona, and some cancer institute from Japan. In Korea, this product has already been commercialized, and we are preparing for export to the United States, EU, and India. Healthcare is ultimately about the patient. Wouldn't you agree? Established knowledge task takes time to validate and adopt into our textbooks, from case studies to retrospective analysis, prospective studies to RCTs. We are on a similar journey. There are no shortcuts, and we are fully committed. This brings me to the final slide and my take-home message. I hope today you've seen the potential of AI ECG. Not only does this technology hold great promise, but realizing its potential demands significant effort, and that responsibility lies with us as researchers and physicians. Additionally, alignment is essential in all of this. Transparency, rational data, utilization, and value-based care must be at the core. Thank you.
Hello, Professor Lee. Can you hear us? I didn't hear your voice. Could you open your mic? Okay. Sorry, we still cannot hear.
Okay.
You. Oh, yeah. That's great. Yeah. Hello. How are you, Professor Lee?
Good. How are you?
Yeah.
Nice to meet you.
Nice to meet you. Yeah. Thank you for your very excellent talk about the AI ECG. Now, in Taiwan, we have our distinguished guest from Mayo Clinical and in Tri-Service General Hospital. So now we have time for open discussion. And are there any questions from our audience?
Hello, Dr. Lee. Can
Hello.
you hear me and
Hello.
see me?
Yeah.
Yeah. Thank you for your inspired talk. I know you has a generative process for the 1 or 2 lead ECG, and in your work you show a powerful. You show the powerful of this generative process. But I want to ask a question about how to use this method for predicting myocardial infarction, because, for example, if the myocardial infarction is for RCA, I guess we don't need that process, and the AI ECG still can perform very well. But for LAD, maybe the generative process is very important, but I have no idea about how well of this method. Can you share your experience for us? Because in your slide, you use the myocardial infarction as an example. Thank you.
Okay, thank you for your comment. And first, I'd like to thank you for the kind invitation. And I couldn't attend in person as I currently in Washington, D.C. And I'm truly grateful for this wonderful opportunity once again. In terms of RCA, on a positive note, we've confirmed that the RCA functionally works well in 6-lead or 2-lead ECGs in myocardial infarction, and we are preparing a prospective study using smartwatch, and are also working on OTC cohort, over-the-counter cohort. However, it's incredibly expensive, labor intensive, time intensive, and money intensive. That said, preparing for MI as an OTC product or smartwatch prospective study present significant regulatory and ethical challenges, particularly with the FDA or something, I think. But in terms of RCA, it works. Thank you.
Thank you. And I think I'm Jinsen Lin in Tri-Service General Hospital. I will spare this wonderful opportunity, and maybe because Professor Zeki Atiyah is here, and maybe I think he will have some comment on your talk. Yeah.
Yes. Thank you very much. Very exciting talk, and thank you for your kind words. I was really excited to learn about the explainability efforts. Can you describe again what each cluster mean, and what do you think it would mean for our patients once you explain these models?
Sorry, could you say that one more time?
Yes,
Clustering?
so I'll try again. Can you hear me? Yes.
Mm-hmm. Okay.
So I was very excited to hear your work about explainability. I'll also discuss it later. What does each cluster in the analysis you have done mean? And do you think it would change how we build AI models in the future if we can do them explainable?
Okay, got it. Give me some second.
Actually, I like this study about explainability and transparency. First of all, I'm planning to step away from MI research and focus entirely on LBSD moving forward. And by the way, I'm a big fan of yours, Dr. Zaki. I love your great work as well. And clusters are quite unique, just as there are various clusters in aortic stenosis, and there are also clusters in LBSD. We find out total of 5 clusters, and cluster A is sinus region with narrow QRS, most of our normal ECG, and second cluster is no ST segment deviation. Cluster C, high average of QRS duration, most prevalent ST depression as well. Cluster D is a slow heart rate, narrow QRS interval. Cluster E has no underlying disease and tachycardia. I believe this could eventually be applied more meaningful in terms of prognosis or treatment plan, but in this time, right now, I have no idea what they mean.
Dr. Lee, that was an excellent presentation. Very excited to see all your great work. Can you tell us a little about the regulatory process and how that differs between Korea and the US, and what does it take to get a product to market?
Hello, David. I'm a big fan of you too. I saw you at AHA 3 days or 4 days a week, 4 days ago in Chicago, and you have very great presentation. In terms of the regulatory process, it's very difficult, but in Korea, we already get like breakthrough designation in Korean FDA, and we have generating revenue. And we use this software, 60 major hospitals in South Korea, and about 100K patient per month, and we pay it. In regulatory process in United States perspective, I think Zaki and David, you're already expert in this area. I think we already in company perspective, I already had a pre-submission with FDA, and we are preparing for FDA approval. Like Anumana. That's it. Thanks.
Hello, Professor Lee. I'm Junsen Lin in Chai Service General Hospital, and I'm also very interested about the policy of, and because now we face a very big challenge when we conduct the clinical trial for the AI product. But I don't know how about could you share the experience in Korea about when we conduct, when we want to evaluate and validate the AI product, and especially we conduct a clinical trial. I don't know the policy of in Korea. Thank you.
As you know, regulatory process is always a challenge. Honestly, it feels like the only way forward is to tackle issues head on as they arise. Licenses vary so much, and there's no one-size-fits-all approach. Hospitals are different, ECG servers are different, IRBs are different. Only way forward is to tackle issues, I think. But regulatory aspect, my thought is that Korea is relatively easy than United States. Thanks. Nice to meet you. I love you guys.
Thank you. Is there any other questions from our audience? Yes.
Okay. Thank you for your excellent talk. I'm Dr. Lee, also from Tri-Service General Hospital. And I want to ask, because we know there are several teams already development prediction model like AF prediction or CAD prediction. But when we try to apply the prediction model to the clinical practice, we know that even the patient already predict at high risk, like high risk of AF or high risk of CAD, but we perform the examination at that time, maybe still show negative result. So how do you think, how we apply this model to the clinical practice? And when we want to deal with this kind of patient, how frequently we need to follow up, like EKG or Holter, or like some more invasive examination? Thank you.
Thank you for your comment. It's struggling. In the Netherlands one, researchers from Netherlands, whose name is Philip Kroon, they're planning a head-to-head comparison of AI ECG model as well. And will the prediction model work well? Will it be useful? Honestly, I'm not entirely sure. There's a lot of prediction models in terms of tradition or something, but I know there are already many teams working hard to prove its value. Zaki as well, and the team from Boston and Taiwan as well, for instance. For now, I believe it's worth trying various approaches and in terms of multi-layer, various approaches, various ways, various subgroups, and various medical environment, whether through RCTs or prospective studies to truly explore the potential of this technology. Thanks.
Still, any questions from our audience? One more. Many questions.
Thank you, Professor Lee, for your Tech Talk level presentation. And I'm Dr. Wu from Tri-Service General Hospital. And given the expertise and deep insight of AI, I have a question for your thoughts on the future. If the AI-based diagnostics tool or fusion models have superior accuracy than current gold guideline, such as diagnosing pulmonary embolism, if the AI model have better accuracy than CTA, and in the future, if it's possible that the AI model can replace or maybe integrate into our current clinical guideline, and what challenges do you think this in the future and this transition could be?
First of all, thank you for your comment. And first of all, we're also conducting research in pediatrics, but it's not easy. There's simply aren't many pediatric patients. And even if AI-based diagnosis proves to be accurate, it will take time to make it ways into clinical guidelines. Right now, many of the models are, how should I say, quite biased. It's from Mayo Clinic, Western side, Eastern side, some specific group, even in Taiwan, I think. While diverse efforts might lead to better integration, implementation is an entirely different challenge. But this is why it's crucial to bridge the gap by applying these technologies to unmet needs in a meaningful and impactful way. And we need to demonstrate their true value through thoughtful implementation. Thanks.
Professor Lee, I just want to ask the adaptability about your ECG T2T model means from 2 lead to 12 lead. As we know that the ECG characteristic is quite very different across the patient with different ages, even body weight or gender. So how can the ECG generating model that generate the 12 ECG is sufficiently accurate among these different population? Did you validate this the accuracy in different model, in different population? Thank you.
Thanks. Thank you for your comment. Actually, T2T, generating technique is achievable as long as we have large data set. It's simple and easy. But that said, generated ECG isn't quite the same as real ECG. It's a bit different. Generated and real ECG is a bit different. What I'm really trying to say is that generating to 12 leads make it much more accurate than 1 lead or two leads. That's what I'd like to say. And actually, there's no standards for comparing ECGs to ECGs. There's no standards, only heart rate or ST deviation or QRS axis, but it's very limited, I think. Thanks.
As the time is limited, so I have to close this section. On behalf of everyone here, I wanted to express our biggest gratitude to Professor Hok-San Lee and for his time and the dedication in presenting such a wonderful talk. And I also wanted to thank you all the audience for your engagement and for your times. Thank you. Thank you. Thank you, Professor Lee. Thank you for everyone. Thank you.
Thanks.
Now we'll take a lunch break. Please make sure to return by 1:20 p.m. During this time, there is an e-poster exhibition outside. If you are interested, feel free to visit the exhibition area. Lunch is also served in the same location. 各位师长，我们外面那个有电子海报可以供参阅，然后午餐也是在同样的地方提供哦。
1、2声。
Good afternoon, everyone. The symposium will begin in 3 minutes. Please take your seats and be ready to start. Thank you for your cooperation. Ladies and gentlemen, the symposium will begin in 1 minute. Please take your seat and be ready to start. Thank you for your cooperation. Good afternoon, ladies and gentlemen. Welcome back to the symposium. To officially begin the afternoon program, we are honored to invite Professor Qinshan Lin to deliver the opening remark. Please join me in giving a big applause.
Good afternoon, President Lee, David and Atia. And it's my great honor to have this opening. Actually, this is the first time that I sit here like this, so I'm a little bit nervous. So, ladies and gentlemen, I think this is very, very good, very excellent experience that we can invite very, very famous international speakers, and also very good topic that we will discuss in the afternoon. So in the afternoon, our topic focus on AI on the cardiovascular medicine. And David will talk about how to deploy and develop this AI model for healthcare. And Atia will help us to talk about from idea to clinical application. And I think we also have the Taiwan experience. And me, we are talking about the clinical trial process. And then Dr. Lin, Professor Lin Qin, we are talking about the foundational model which is established in our hospital. And we also have the Professor Zhang from Taipei Medical University. She is talking about the use the large language model to perform and to evaluate the AI algorithm and the AI product. So nowadays we all recognize that for clinician we need to collaborate and we need to communicate with AI. And maybe usually people said that the clinician who is not use AI will be replaced by the clinician who use with AI. So nowadays we need to use and we need to communicate with AI. So that's why we need to have this transformative transformation. So I think I hope you guys will have very fruitful experience in the afternoon. Thank you. Thank you.
Thank you, Professor Lin. Now we'll take a Professor David Ouyang, and moderating this session will be Professor Yi-Hen Lee.
I thank the organizing committee for inviting me to chair this very important talk. So it's my great pleasure to make a very brief introduction of Dr. David Ouyang. David was graduated from the University of California in San Francisco. He obtained his medical degree there. Then he received his clinical training in internal medicine and the cardiology training in the Stanford University. So currently, David is the staff physician and the assistant professor in the Cedars-Sinai Medical Center, which is a very famous hospital in the United States. And I saw his CV. It's to my surprise, in such a young age, he has already published more than 100 papers in such a high-ranking journals like the Nature Medicine, Circulation, etc. So he's a real expert in the artificial intelligence, especially how to apply this new technology to our daily clinical practice. So today, I think he will share with his experience in developing and using the AI, especially for the cardiovascular medicine. So let's welcome the Dr. David Ouyang for his talk. David, go ahead.
Dr. Lee, thank you so much for the very kind introduction. 谢谢大家，我很感谢来这个机会来跟你们交流，然后来到台湾。我的中文不太很好，所以我就是 rest of the talk 我会说英文。All right. So today I'll focus on the integration of AI, particularly with echocardiography or cardiac ultrasound, because as both from the work from Dr. Zaki, as well as Dr. Lin and many others, you guys are really the experts for EKG. So I'll really focus on cardiac ultrasound. A little bit about the background, why it's particularly use AI, clinical need, where there are certain aspects of medicine that might benefit. Aspects of medicine that might benefit from further development, or necessarily clinicians might have additional benefit from assistance. And then 2 vignettes in terms of what AI in echo looks like, both in terms of precision measurement as well as precision detection of disease. So first, before I begin, I often like to start with a picture not even in cardiology. This is a picture that was published in the New England Journal 10 years ago, which simply shows a truck driver. You can see that in maybe 20 or 30 years of driving the same route, he had symmetric sun exposure. So you can see that the left side of his face is very different from the right side of his face. For me, this is a perfect encapsulation of why medical imaging is important. It gives you information about the phenotype that reflects the environment and the inheritance, that he's Caucasian and that he has a lot of sun exposure, that ultimately relates to a clinical outcome of interest. For him, it might be skin cancer, and it might be something that if we were to see him, we might recognize that it's actually different in terms of risk from the left to the right side of his face. As a cardiologist, we know there's many important cardiac measurements, things like ejection fraction, coronary calcium on CT, SCAR on MRI. But ultimately, at the end of the day, those are all measurements that humans have thought of. And we also know that these measurements have changed over time, particularly for MRI assessments, things like SCAR. That was something that was not very popular even 20 years ago. So our understanding of what are the most important imaging features have changed over time. So ultimately, most of the measurements and assessments that humans can do from the imaging is like the tip of the iceberg. There's so much more additional information, things like the wrinkles of his face or a lot of imaging in echo or CT or EKG that is not in the report itself, that is currently underutilized. And really, that's the opportunity with AI. Can we actually identify more features or more tasks that AI can do that might benefit clinicians or can allow AI to do with more precision than clinicians? The second piece is that clinicians need AI because there's tremendous clinical variation. If you see 2 different doctors, not only you might get 2 different diagnoses, you might get 2 different treatment plans, and you might get 2 different results. This is true in all forms of imaging and all forms of medicine, but I'd like to highlight that this is true even for our most basic measurements and most basic assessments. So one example I like to give is the ejection fraction. It's a measure of heart function, and it's a ratio of the heart size at its largest versus at its smallest. And here, on the left-hand side, are 2 histograms where I've colored whether the ejection fraction ends in 0 and 5 in red, or ends 1, 2, 3, 4 in blue. And you can see that even when humans measure ejection fraction, they are imprecise and they actually have bias. Humans are much more likely to report the ejection fraction as 20, 25, 30, 35% or so, compared to 34 or 66 or 78, even though it is a quantitative assessment. At the same time, the ejection fraction is a ratio, that volume at end systole and end diastole. So you can see that this pattern does not occur when you actually look at the histogram of end systolic volume or end diastolic volume. Now, you might ask, why is that true and why is that possible? My hypothesis is that it's due to human bias or human variation. When doctors are unsure, I might say something at a threshold. So I might give a number of 50% when they might have heart failure, but they might not, but is a young patient and needs to get chemotherapy, and I don't want to stop the chemotherapy. It might be, I say 35, when I want to leave it up to the electrophysiologist to decide whether they want to put in a pacemaker or not, instead of calling it 34 or 36, which might change their decision-making. Ultimately, the literature suggests that even for our most simple measurements, there's tremendous human variability. So the ejection fraction has a variation up to 8 to 14%. And a lot of the things that we're taught to do, we don't routinely do. One example I like to give is that the American Society of Echo recommends that we actually measure the heartbeat 5 times to assess ejection fraction in a single study. This is so that it minimizes variation from beat to beat, but we rarely do this in a true clinical echo lab. We either visually approximate or we actually just measure one beat and say that it's the representative beat. And I'm an echocardiographer by work, meaning that I read echoes, but I also want to highlight this is true in all facets of imaging and all forms of imaging. One example I like to give is that MRI is often thought of as a gold standard, that is a more expensive and fancier technology, so it might have better images. But because it's more expensive, we actually have fewer studies that assess the variation when 2 different cardiologists or 2 different radiologists look at the same images. And when those studies are done, that variation is just as high as it is in echo. So on the left-hand side is a paper published in Lancet Digital Health, where it actually looked that the wall thickness, something super simple, just a linear measurement, actually has a lot of variability, not due to the quality of the image, but due to how clinicians measure it, right? You can see in this picture that different radiologists measure at different frames, different parts of the heart, different beats, and ultimately, all of this synthesizes to that the MRI has as much variation as echo in some of our most basic measurements. So ultimately, this is where AI can be helpful, right? Is there opportunities to reduce variation in practice and reduce variation in measurement? And can it also do tasks that humans cannot do? So this is an opportunity to find additional value in the imaging or in the studies that we already acquire. So now 4 years ago, we published one of the, let me see if this will play. That's great. It doesn't look like the videos are playing, but 4 years ago, we published a paper where we developed one of the first video-based models for echocardiography. What this looks like is that in black and white is an apical 4-chamber video of the heart, and in blue is actually the segmentation, or what the model thinks is the left ventricle, and in yellow is what the rest of the heart thinks it is. And this model both creates that segmentation as well as a point estimate of the ejection fraction. Even many years ago, say in the 90s or prior, there have been products that suggest that software can calculate ejection fraction. But the main Achilles heel for those products has been that it does not work very well in images that are low quality. The Achilles heel of echo is really that there are low quality images, particularly if patients are either more obese or have lung disease or are smokers, so that we still want to capture and measure those measurements. Human cardiologists are still able to assess those measurements even when it is a low quality image. But prior to deep learning, or prior to deep learning computer vision, that was not possible. So our model, which we published in Nature now 4 years ago, we were able to show that it actually is able to both trace the high quality images on the left-hand side, so those are 2 echoes that are considered high quality, as well as 2 videos that are low quality on the right-hand side. And you can see that these are ones that actually would be very representative of what a traditional echo would look like, but it can still measure every single frame and every single beat. The second piece is that when you can actually use software, this allows for more precision. One example I like to give is that there is natural variation in the heartbeat, in the heart cycle, that actually impacts the ejection fraction. So I wish this video was playing, but it means to show is that when there's atrial fibrillation, you can even visually tell when there's certain frames or certain beats that are bigger and certain frames that are smaller. And that results in a smaller or different choice or a different ejection fraction when you measure it based on what beat you choose. Now again, humans, because it's very laborious to do this measurement, will only choose one, but that causes heterogeneity or variation based on which beat it chooses. In the bottom right, what we're trying to show is that because software is able to measure every single frame and every single beat, it allows for a more precise point estimate, because you can see the more number of sampled frames, the more number of sampled beats, the lower the error is. So I would say that at that point, we were very excited, and a lot of the conversation today has been about what it takes to actually then deploy such models in the actual clinical system. This is something that I think Taiwan and Dr. Lin's group has done very well, but at this point, we were evaluating what does it look like to actually implement these technologies in the United States. We evaluated for the United States FDA what it took to get regulatory approval. And at that time, there are only 300 AI models approved. Right now, there's about 1,000, but this still is consistent and true, meaning that for FDA approval, very few actually reported multi-site studies. The vast majority only used retrospective data, and none actually showed randomization or blinding in the assessment of these models. The reason I highlight this is as clinicians, we know the clinical trials that we use when we think about a device or a drug often are prospective clinical trials that have randomization and have blinding. Unfortunately, the current regulatory environment, and even the prior speaker have said that they consider the US FDA is actually stricter than others, is actually much lower for AI than it is for, I would say, than other products that we use in medicine. So at that time, now 2 years ago, we decided to conduct one of the first clinical trials of AI in echocardiography. This was a late breaker at ESC in 2022, where we conducted a blinded randomized trial of sonographer or technician versus AI in the assessment of left ventricular ejection fraction. So I'll walk you guys through it a little bit. So in the US, and I think this is also true in Taiwan, is that oftentimes a technician or a sonographer scans the patient, produces a preliminary assessment, and the cardiologist finalizes this. In the Cedars-Sinai Echo Lab, we have about 25 sonographers, a mean of 14 years of experience per person, and then we have 10 cardiologists with a mean of 13 years of experience. This is a really interesting place to evaluate AI because by definition, two experts look at the same images at two independent time points. Oftentimes our workflows are such that the sonographer and cardiologists don't even talk. They're on different computers and they don't actually see each other to communicate, but require two different touch points to assess the same images. In this setting, we actually blinded cardiologists to whether it was a preliminary assessment done by the technician or sonographer versus it was done by AI. We actually replaced half of the annotations that the sonographer did and then showed AI annotations. And then we evaluated how frequently the cardiologist changed the measurements when it is AI versus when it is sonographer. And we also asked the cardiologist to guess whether it was AI or sonographer for every single study. There's three main changes that we made from our original Nature paper that I want to highlight. And this is work run by Brian He, who's a Stanford CS PhD student, which is first, we really wanted to blind the cardiologist to AI. Even though I just showed that the AI can measure every single beat and every single frame, our sonographers usually only measure one beat in two frames, the end systolic and the end diastolic frame. As such, we made it so that the AI only looked at one frame and only annotated one frame, so the cardiologist cannot tell just based on the annotation which it was done by AI or sonographer. The second piece is that this is true both in general AI as well as in kind of medical AI, is that the scale of data is incredibly important to the quality of the model. One example I like to give is that for ejection fraction, there have been already many echo AI models. But if you look at their FDA paperwork, they've trained their model on 100, 600, or 1,000 examples. Whereas we know that generally the performance scales with the amount of data. ChatGPT is trained on the internet's worth of data, and that's why it does very well. If you had the same code, but just on much lower data sets, it would perform much worse. So in our original paper, we trained on 10,000 echo videos. And then for this RCT, we actually continue training the model with up to 144,000 echo videos with the hope of improving the quality of our model. So this is an example of what it looked like in our clinical workflow. I'm glad this video is playing. In green is what it looks like when a sonographer or a cardiologist traces the ejection fraction. So you can see these tracings that are done. This is actually done by a sonographer, and this is in the system that the cardiologist sonographer uses. Here, we're running some code, and I want to show you what it looks like when it's done by AI. So this set of tracings were done by AI. We put a lot of work into actually implementing the AI into our clinical system because we wanted to evaluate sonographers and cardiologists in exactly the same clinical environment and clinical system that they're used to, so there's no bias in terms of what it looks like, or they're very familiar with the system already. The last piece is, even if you are not interested in AI at all, a key interest of mine is what it means for clinical variation. We intentionally chose 4,000 studies from the past so that for every single study, we already have a clinical report. That clinical report already has a left ventricular ejection fraction, so that even if you didn't care about AI at all, you can look at the sonographer arm to actually use the blue two arrows to evaluate human test retest. Our prior analysis was that the literature suggests that the prior evaluation of EF variability in humans is limited by studies that are maybe 50 to 100 studies or so. Because we're doing a clinical trial on 4,000 studies, this will be the largest point estimate of human variation in assessing ejection fraction. So we started with 3,800 echoes. About 7% were too low quality so that it was visually approximated for ejection fraction. And then we ended up with 3,500 echoes that were annotated by the sonographers. About half were shown directly to the cardiologist, and half were removed and only shown an AI assessment of the ejection fraction. These patients generally represent the Cedars-Sinai patient population, where it's a little bit more male, it's diverse, and it's a lot of cardiovascular comorbidities. I like to show this slide particularly to an audience that have cardiologists, because this gives you a sense of what it looks like if you were actually a participant in the trial. In the middle are 3 apical 4-chamber videos, and on the left and right-hand side are 2 set of tracings. For every single study in our trial, we asked the cardiologist to guess whether it was performed by AI or sonographer. And I want you to see if you can tell on the left-hand side or the right-hand side, if you were to see these images, which you would guess. Yeah, so I would say that it's very hard, and I did switch them back and forth by each row to make it a little bit harder for you guys. But in our clinical trial, the cardiologist could not distinguish between AI or sonographer initial assessments. They guessed it was AI, and it was truly AI, or sonographer and it's truly sonographer 33% of the time. They were incorrect, so they were very confident it was AI, but it was actually sonographer or vice versa, 25% of the time. And 43% of the time, they were actually said, this is too close, I cannot make a prediction. This results in a blinding index, which is a measure of how good the blinding is, of 0.88, of which negative 2.2 to 0.2 is considered good blinding. So I wanted to emphasize these results even before I get to the primary results to show that this is actually a well-blinded trial. So in this study, substantial change meant more than a 5% change in ejection fraction from the prelim to the final assessment. But in the AI arm, the substantial change happened 17% of the time, versus in the sonographer arm, it actually happened 27% of the time. So we actually powered the study to be a non-inferiority study, where as long as kind of AI was non-inferior, we were happy. But this had a p-value of less than 0.001, both for non-inferiority as well as superiority for the AI arm. The mean absolute difference in ejection fraction was 2.8% versus 3.8%. And for the final versus historical assessment, it was a difference of 6.3% versus 7.2%, also suggesting that AI actually improves reliability or consistency across time. And we can tell that on average, this saved 2 minutes of sonographer time per study, 10 seconds of cardiologist time per study, and resulted in having to do fewer changes over a larger population of studies. There's a couple limitations I do like to highlight, where this is single center. This was done in the Cedars-Sinai Echo Lab. In order to blind, the AI was weakened. There was no comparison with MRI or CT. And there's further work that needs to assess long-term impact. But despite these limitations, we're very happy with this study because this is external validation of an AI model with publicly available code and representative training data. So compared to all the other, or many of the other Echo AI models out there, we actually release much of the training data and all of the training code so that you can actually train it yourself and evaluate the model on your own echoes. Similarly, this model was only trained on Stanford echoes, so this is external validation, meaning the training data and the test data were from 2 different places. This is one of the few echo trials that had randomization with an active comparator. The sonographers themselves are experts and are very much integrated into our workflow. And most AI trials either don't have an assistance or are actually completely blank. And we show that the blinding was truly very successful. And finally, even if you're not interested in AI at all, this is the largest study of clinician test-retest of ejection fraction. So, and we're proud to say that actually we submitted a lot of this paperwork as well as others to the US FDA and received FDA approval in April of this year. So we are currently using it in the Cedars-Sinai Echo Lab, and we're hoping that many other Echo Labs will be able to use this technology. The second vignette, which I want to describe, is precision detection of disease. And again, this is an area where I think there's even more heterogeneity and variation than measurement. I like this vignette because this is a true patient we have actually seen, which is an 82-year-old gentleman with heart failure with a preserved EF, AFib, sick sinus syndrome, and left carpal tunnel syndrome surgery. He received many echoes in 2019. So you can see on the right-hand side, actually had maybe 6 or 7 different echoes around a 6-month period. He received an EKG that does not meet low voltage criteria, and he had a wall thickness of 1.3 centimeters based on the sonographer measurements. And I highlight this because this is actually something that now there's much more interest and much more diagnostic information about, but this is someone that in hindsight might be very suspicious of cardiac amyloid. So you can see maybe the sonographer under-measured the wall thickness, where the true wall thickness should be actually more than 1.3 centimeters. But ultimately, this was a diagnosis that was not caught even having many different cardiologists review many different imaging tests for this gentleman. So this is true, I think, both in Taiwan as well as in the US, is that this is still a very underdiagnosed disease. In the US, it's suggested that patients see up to 4 specialists and take 2 to 3 years of evaluation and many different tests before getting to that diagnosis of cardiac amyloid. This is unfortunate because there are actually new therapies that actually improve mortality and improve the quality of life. And many of these treatments, particularly Helios B, which was presented at ESC this past year, suggest that the impact is even higher when it's earlier in the disease state. So in this setting, we developed an automated workflow to assess cardiac amyloid. First, we have precision measurement of wall thickness. And this is a similar story to our ejection fraction story, where we actually measure the wall thickness in every single frame and every single beat that allows for a more precise measurement. And you can see that in this model, it actually can avoid some of the traps that other models with less training data can fail at, which it might detect the pericardial effusion or measure that as the posterior wall. We show that this actually results in less variability from study to study compared to humans, where you look at multiple studies from the same patient. This is what it looks like in terms of the scatter plot of what the human measurements look like for many of these key measurements versus what it looks like with our model called EchoNet LVH. And then once we've identified patients with left ventricular ejection or left ventricular hypertrophy, we actually identify the etiology. So there's many causes of LVH, including cardiac amyloid, HCM, hypertension, as well as kind of aortic stenosis. This is a model where it's balanced on the wall thickness so that both the cases and controls actually identify which type of disease it is, and ultimately results in a highly specific diagnosis of cardiac amyloid. So I like to say this is a particularly interesting use of AI because software does not fatigue. In the US, there's about 7,000 to 10,000 cases of amyloid diagnosed each year. However, if we were to truly measure the incidence of cardiac amyloid, for example, in the case of aortic stenosis, which is based on the number of patients with aortic stenosis, and multiply by essentially autopsy results that suggest maybe 15% of patients actually have cardiac amyloid, that there should actually be 20,000 cases in the US. Or if you actually identify the number of patients with heart failure with LVH, there might be even as many as 220,000 cases of cardiac amyloid each year. At the same time, about 1 in 5 patients over 65 in the US get an echo every single year. So this is a very highly prevalent test, and there's a lot of information out there that are going back to that original picture of the truck driver, a lot of missing information that is not being used in standard clinical care. So we're currently running a 4-center prospective trial, which is actually done at Cedars-Sinai, the Palo Alto Medical Center, Northwestern, and Providence. And actually, the site PI at the Palo Alto VA is actually from Taiwan. It is Paul Chang, who's also a Stanford physician. And we're actually prospectively looking at all the echoes that are high risk, but do not have a prior diagnosis of cardiac amyloid. So this is what it looks like. And I apologize because I think the color's not very good. But on the top is the histogram of model predictions when you look at all the historical echoes at a certain time point. You can see that many more are 0, so low risk, and very few, close to none, are high risk. But if you actually look at the patients that are high risk, many of them actually have a ICD-9 code diagnosis of cardiac amyloid. So our trial is actually looking at all the historical echoes, finding all the high prediction patients, and then removing the ones with the prior diagnosis of amyloid and calling those patients that do not have a diagnosis for further evaluation and potentially future diagnosis. And that vignette that I showed earlier of the 82-year-old was actually one such case at Cedars, where even though he did not have a diagnosis, he was seen in clinic, he still had heart failure symptoms even 4 years out, and then actually was diagnosed with TTR amyloid and was actually started on vutrisiran and feels much better. So I like this concept and this framework because it's an idea that applies for all forms of imaging, in which whether it's cardiac amyloid or mitral regurgitation or even liver disease, that by sheer nature of using software and being able to consolidate and organize large data sets, we're actually able to have a more precise assessment of many diseases that we see routinely. So one example is that for mitral regurgitation, in the US, there's currently a lot of interest in mitral clip, so that our interventional colleagues want us to come up with a list of high suspicion patients of moderate plus MR that might benefit from mitral clip. So similar, we're able to actually pull through all the echoes in the past and actually flag the patients that might be better seen in an interventional clinic. The last piece I'll end with is ultimately, we do know that for AI, performance scales with data. And this is true for ejection fraction, and this is true for many other measurements. We recently produced a foundation model, one called EchoClip, and actually most recently one called EchoPrime, which actually is trained on 12 million echo videos. So this is what it looks like. By training on 12 million videos from over 300,000 studies from Cedars, we actually can create a model that actually identifies the most relevant view for any prediction task. So you can see this is looking at the rush wall motion, so it actually identifies those views in the middle, and then creates an impression on the right-hand side. You can see for the left atrium, it identifies views that actually have the left atrium in mind, and actually also produces that assessment, and vice versa. And it does this for the entire echo video. By building a foundation model that actually identifies every single interpretation in an echo report, we can actually automate the evaluation of echo in a high throughput way. Because echo has many videos in a single study, we were actually very intentional to build in an understanding of which views are most important. So this is using something called multiple instance attention learning, where we actually identify which views actually have which anatomical structures and which views are actually most relevant for any particular diagnosis. And this is work done by Milos, which is one of the graduate students in the lab. And we think that this actually produces a model that actually produces many high-quality interpretations for all the different echo assessments and allows us to do tasks that would be even hard for clinicians. One example I like to give is if you saw 2 different echo videos, would you be able to identify if it's coming from the same patient or a different patient? I would say even for me, I think that would be very hard, unless it's very obvious one person had a valve surgery and one did not. But this model is actually able to detect very well with an AUC of 0.8 or so to actually identify whether it came from the same patient or not. This subtle variation detection is something that is incredibly important, and it allows for actually more precise assessment of echocardiography. So I'll end with 2 last pieces, projects that are done by one of my kind of postdocs, which is Yiming Xu, who is also from Taiwan and was actually in my lab for this last year, which we're excited about essentially the use of AI through all forms of cardiovascular imaging. One example we gave, this is published in JACC-EP, is this is already work that I know that many of you guys have already done, but we actually produced an EKG-based model to evaluate hyperkalemia, and we show that this works particularly even in patients with ESRD and EKGs obtained from an Apple smartwatch. This actually led to an AUC of 0.8 to 0.87 that it can actually identify when someone is hyperkalemic right before or right after dialysis. And another work that Yiming's also done is actually the understanding and evaluation of echo for the assessment of pericardial effusions in assessing whether it's small, mild, moderate, or large versus whether there's tamponade. This is similar using a multiple instance approach where we actually use the assessment of effusion from many different views, because for pericardial effusion, it might be present in some views and not in others, that allows us to synthesize and aggregate this information and results in a very strong prediction of whether there's cardiac tamponade as well as pericardial effusion. And ultimately, I know that this is something that we're all really excited about, but I do believe that at the end of the day, we're all building out larger systems, and then we're building out multiple data models. So this is an area that I think is incredibly exciting, and looking forward to collaborate with you guys on. All right, thank you so much.
Thank you, David, for your excellent talk about what you have done already about using the AI in clinical medicine. I'm so impressive about all these studies. So we still have time for discussion. So any discussion, any question from the floor? Professor, go ahead.
Very fantastic work. Congratulations. So David, as a clinical physician, I have 3 questions. One, the first, how about the cost? If our hospital want to implement this system, maybe we are very interested about this system. And second, I think you guys did a lot, very fantastic work to evaluate all the echo parameters by AI. But usually we know that it is also technician dependent. So do you evaluate that if a different technician, the AI can overcome this kind of problem? And third, I think we all now know that from the very large scale screening, we can identify the previous near-miss disease, as you mentioned, the cardiac amyloidosis. So I just wonder how many, since you implement this system, how many patients you have identified if you previously undiagnosed patient?
Yeah, no, those are, Dr. Lin, those are 3 excellent questions, and I'll try to go in order. First, my lab takes a lot of pride in sharing code and weights for every single project that we do. I think that this is something that is consistent across computer science, and unfortunately not always the case in AI and medicine. But if you were to implement any of our models, it should be free for you. So if you ever wanted to run any of these things, as long as you have a computer, which I know that you guys already do have here, you don't even have to talk to me. You can just go on GitHub and download it. Well, obviously, we would love to work with you and definitely give you suggestions if certain things aren't working, but I believe that's truly in the spirit of open science. I think that a lot of the work that we do in terms of pushing it into a product, that the part that's expensive is a lot of the regulatory work. And obviously that is necessary in order to sell something, but especially in a research setting, we really want to share it for free. The second question is what it looks like for human heterogeneity in terms of sonographer quality. So I think that that's an important question and is very true, where we've actually done some work even in point of care echo. So echo is done in the emergency room, oftentimes with emergency physicians that are not as well trained as the sonographers, have images that are very different. And at that point, it does require some fine tuning to use it at that stage. But we have found that our models tend to generalize very well across sites. And we expect that in the many different sites in the US, there's many different variable quality of sonographers. As long as they're a sonographer within that range of quality, generally it's okay, and it's pretty robust to that. And I forgot, Dr. Lin, what was the third question again? Can you say that one more time?
How many patients you have identified the near-miss patient use this kind of system with regard to the amyloidosis?
Yeah, no, that's a really great question, and that's why we're running the prospective trial. Because the echo does not define the disease, meaning that even if it's very suspicious by AI, it needs to be seen by a cardiologist and needs the nuclear medicine test to confirm afterwards. But I will say that we have roughly 300 patients in about 100,000 patients that are suspicious enough that we want to call back to see in our clinic. And it is still very early in our clinical trial. We've only enrolled 5 people. But among the 5 people that were enrolled, 2 have already been positive. So we're very excited that we are identifying missed people.
Yeah, go ahead, Dr. Lee.
Okay, thank you for your inspired talk. I have 2 simple questions. The first question is in your slide, you developed 4 echocardiogram AI model. In fact, you used a different training method for them. The first 2 model, you use the segmentation model to train the AI, and the third and fourth model, you use the echocardiographic report to train the model. In fact, you also can use the ejection fraction value to directly train it. So can you share your experience to compare these 3 kind of model training process for estimating the ejection fraction? The second question is how to integrate multi-modality data into the foundation model, because now in your work you use the echocardiographic report as a kind of label to train the model, but now you want to use multi-modality data into the one model. I guess that is the right direction, because the information in the echocardiographic report is limited. So if we want to let the AI to do something human cannot do, we need to integrate more information to AI. So that is my second question. Thank you.
Yeah, both are important questions, and I think that there's a high-level meta question, which is how to choose questions or how to choose problems. I think that's ultimately why I think it is very helpful to have both computer scientists as well as cardiologists at the table, because you both need to understand what is clinically meaningful and what's also possible. With a lot of places where you only have one expertise or the other is insufficient. And in fact, I would say that's probably why I think that, both for my lab as well as your labs, people are gravitating toward echo and ECG, because there's large scale data, right? Generally, I would tell my students is that I prefer projects where we have a lot of data. even if it's more imprecise or it's a little bit weaker of a data set. I would much rather have 100,000 weak labels than 100 good labels, because 100 labels is insufficient to train a really good model. And oftentimes, that's the paradigm that we have when it comes to CT or MRI. I think for the multimodality question, a lot of it is really, in this setting, we try to use primarily contrastive learning. So rather than using the text report, but you can think of the text as an additional modality, you want to train it contrastively so that all the training examples are bound by the patient level information. So that you can imagine kind of, particularly when you have multiple modalities, you have a lot of challenges with missingness. Some people might only have an EKG, MRI, and echo. Some might have a CT and EKG, and vice versa. So you need to both handle what it means when there's differences in time, and EKG and echo might be more tightly bound when it's like within a day versus within 3 years, and what it means when it's different from one patient to the other. So there's definitely a lot of different wrinkles, but generally I consider the models to be foundation models when it's contrastively trained on large data sets.
Actually, I'm so impressed about your the clinical trial, the randomized clinical trial between the echocardiographer and the AI. I'm curious about what was the percentage of discrepancy between the echocardiographer and the AI. Let's say the AI say it's a poor LV function, but echocardiography say it's a normal LV function. So what's the percentage in that trial?
Yeah, no, that's a really good question. The one thing I like to highlight oftentimes, actually I don't think we have the slides up anymore. But
可以放那个幻灯片吗
？Please.
So why I'm asking this question is, right now in your echo lab, how do you resolve the conflict between the AI and the physicians?
Yeah. The simple answer, or generally the FDA cleared answer, is that it is under the purview of the clinician. So that the clinician should ultimately decide what they think is right and what they want as the final number. That's not meant to override them, particularly for things like ejection fraction. But the reason I wanted to put up the slide is that actually humans are very susceptible to anchoring bias. So that's what I wanted to highlight, whereas that if you look at the difference between prelim to final versus historical to final, you see much more variation when you don't actually know what the other number is. When it's either sonographer or AI, the cardiologists are less likely to change it. They'll put it just like 3% off, versus like if you don't see it and you did it yourself, it's more likely to be 6 or 7% off. So, humans are fallible, and what we see also makes us second guess ourselves a lot. I wish I had a better answer, but it ultimately does show that prospective trials like the ones that Dr. Lin have done is important, especially because it essentially studies the human-computer interaction.
That means in the near future, we are facing a situation that is, there will be different interpretation of the same medical imaging, the same ECG it's possible that between the AI or a physician.
Yeah.
So there will be more and more such kind of conflict.
Yeah.
So I'm just curious how to resolve such kind of problem in our daily clinical practice. I think the physician will decide by himself because he signed a report. He's in charge.
Yeah.
Okay.
Yeah. No.
What's your opinion about this?
It's a tough question. I don't think that there's like a full answer, but it is ultimately what we're dealing with, right? We're going to get more and more information, and we have to decide how much that changes our clinical practice. The one thing I would say is that I think it's on us to know how to handle bad data, right? One example I like to give is that, lab work, intrinsically, we know sometimes we don't trust it when it's hemolyzed. Like if you see a potassium of 6 or 7, it's still the same data on the number, but then you realize, oh, this is probably not correct. Human cardiologists and clinicians need to also build that intuition for AI, right? It needs to know, actually, this seems completely wildly off and I don't trust it. And you can't ultimately just rely on AI to do everything.
Okay, thank you. For LV ejection fraction, it's still a MO study work for LV ejection. So how about the progress now, right in the, let's say the mitral regurgitation, aortic regurgitation. So AI now is smart enough to quantitate the severity of the valvular heart disease?
Yeah, we use a view classifier to identify when there's color Doppler, and we use the color Doppler to assess classifications. So it doesn't do it the same way that cardiologists might do, where we measure an ERO or SUP, but it does give a gross assessment of like mild, moderate, or severe.
Any other question from? Go ahead. Please go ahead.
Thank you, Professor David. I'm Dr. Lin. I'm a cardiologist, electrophysiologist. And I saw your presentation, a very nice presentation, and show us the AI can enhance the accuracy and efficacy in cardiac function assessment. And I just wondering about the impact of the premature ventricular complexes when the PVC occurs, the beat variation, and the various stroke volume.
Yes.
But how the AI model can, because for the human, we can ignore the PVC evaluation, but how AI, or is there any changes in the accuracy when they assess the patient with PVC, especially frequency PVC?
I would say that's an excellent question. And if I had to say, the human guidelines are actually not very good, right? For example, if someone is in bigeminy, what do you think the ejection fraction is, right? Like, is it just that one representative non-PVC beat and that is the true representation? That's actually a little bit unclear. Or if there is a lot of PVCs, should we inherently believe there's a lower cardiac output than someone that doesn't have PVCs? Our general approach for our models have been that we measure every single thing, but we actually will then measure 5 beats. So hopefully there's only one PVC, and it averages it, but it does not try to remove the PVCs or something like that. I think that this inherently gives a more realistic reflection of what it looks like on a broader spectrum. But I think that it speaks to even clinical variation in terms of, I'm not exactly sure how maybe I might be less generous with a bigeminy patient or not in terms of ejection fraction.
Any other question from the floor?
May I have a second question about the mechanism of the hypertrophic cardiomyopathy? You said that the AI model also enhances to differentiate the underlying etiology of the hypertrophy. But I know that some AI ECG also has the potential to differentiate the underlying mechanism. So what's your opinion about between the AI ECG and the AI echo for the assessment of hypertrophic cardiomyopathy?
I was going to say, Zaki and I can have a debate over this. So this is definitely opinion and not a fact. But the reason I highlight our model there is that we were very intentional in the design of the model to balance the cases and controls for LVH, meaning that there are other published echo models where you don't balance, where let's say it's cases of amyloid and they're all thick heart muscles, and your controls are all just normal patients. By nature of that, the model very easily shortcuts on the fact that there is purely LVH, so that we show in our paper, if you actually truly use a model like that, it will call patients with hypertension as amyloid as well. It will call patients with HCM as amyloid as well. It will shortcut on these features that you don't intentionally balance for. And I think that that's the piece where functionally it is much harder to balance a lot of these characteristics on ECG. You still can, and it's just a question of kind of the cohort design. But we think that the echo allows for more specificity by sheer nature of that design.
Okay. Any further question? If there is no further question, I would like to, on behalf of the organizing committee, I would like to award David Ouyang a certificate of appreciation. Thank you for your contributions to this meeting.
Yeah, thank you so much.
We can, next session, I would like to invite Professor Zhang to chair the next. The Dr. going to chair the next talk? Okay, Dr. Ding, please.
Okay. Okay, it's my great honor to be the moderator for our distinguished speaker, Zaki Attia. Zaki Attia is an AI developer for in Mayo Clinic. He developed a lot of AI ECG system for predicting low ejection fraction, paroxysmal atrial fibrillation, and so on. His work inspired us a lot of, so we put our effort to the AI ECG after his work. And today's morning, our another distinguished speaker also say he is inspired by Zaki's work. So we are very happy to have this opportunity to invite Zaki to give us his new work. Thank you for Zaki. Now we can start it. Thank you.
Thank you very much. And first, I want to thank you for inviting me. It's a great honor and it's a great meeting. My first time in Taiwan, so I was very excited as well. And you're hosting us wonderfully, and we learn a lot from each other. So, as Dr. Lin said, I'm from the Mayo Clinic. These are my disclosures. I'm going to touch AI ECG and then maybe show how we use AI in real life. Then talk about explainability, and if we'll have the time, we'll discuss Echo AI, but David gave such a great presentation, we might shortcut it a bit. So when we think about AI in healthcare in general, we think about two ways. One is doing what humans can do, but doing it in a more accurate way, as we've seen, do it in a more automatic way, allowing it to be a first-person interpretation, and allow scalability. The second thing is trying to go beyond what humans can do, seeing what clinicians cannot, moving beyond normal and abnormal, and maybe most important is adding value to existing medical tests. And that's the reason we chose the ECG. As you know, ECG is done in every hospital hundreds of thousands of times. It's a very, very simple test, and the idea behind it, as you all know, is that if you put an amplifier on a myocyte, you would get this activation. If you collect all the activation from the body surface, you will get that ECG. And physician knows how to look at an ECG and say this is a STEMI, or this is atrial fibrillation. But we said maybe this electrical activity can be a fingerprint of the heart. Maybe we can learn more than what we already know. And when we started by using machine learning. In machine learning, you would take the ECG and you would convert it to human-selected features. You would say, this is the QT of the patient, this is the QRS width, this is the RR interval, and so on. And this is, for many years, how we built models. But the problem is, this is a biased concept because we only select features that we think are important. We only write the features that physicians think are useful for that specific problem, and it's also done not in a very accurate way. For example, measuring the QT, you need to know the end of the T wave, which is not a simple task. And on deep learning, on the other hand, we just take the signal and feed it as is. We just look at the raw numbers, raw voltages. It is unbiased and optimized during training, but it is not explainable. So we do not know what we're looking at. And when we train a model, we follow a very simple routine, which most of you know. You just take the neural network, you feed the label during training, and the model select the features that are important and predict the probability of a label. It can be the probability of a disease, the probability of being a man, and so on. During testing, we take the ECGs in a blinded way, and we compare them to the actual label, and we get the AUC. And I want to talk about low ejection fraction just because it's been validated, and the concept of this talk is taking from an idea to a medical test. And this is an idea that Professor Friedman had many years ago. He said, we know that we cannot look at ECG and say what's the ejection fraction, but maybe AI can. And as David mentioned earlier, the ejection fraction is the ratio between the amount of blood that is pumped out to the amount of blood in the chamber. It's considered probably the most important measurement in an echo. And the decrease in EF might start with no symptoms. And we know that by treating it, we can improve patients' lives, quality, and longevity. The problem is that doing it with an echo, even with AI, is not very good for screening. It's great for diagnosis, but we have so many patients that would suffer from low ejection fraction at some point. Population is growing, people are getting older. We need to find a more scalable way to do the screening. And again, as I mentioned, Professor Friedman kind of asked, maybe an AI can do it. And we started by collecting patients that had both an echo and an ECG within 14 days. We started with about 600,000 patients. We cleaned the data a lot until we got 100,000 pairs. We used about a third of them to train the model, 10% to fine-tune it and find the optimal parameters, and tested it on 52,000 patients. This was published in Nature Medicine a few years ago. At the time, AI ECG was a new thing, so we took some convolutional neural networks that were built for images, and we adapted them to work on ejection fraction from raw ECG, and we selected EF of less than 35. And many of you can guess the reason is that Dr. Friedman is an electrophysiologist, so he cared about the 35 threshold. We later on adapted it to EF of less than 40. We tested it using the ROC. As you know, an ROC of 0.5 is a random test, 1 is a perfect test, and we had an AUC of 0.93 with a sensitivity of specificity of 86%, better than most medical tests used today. And then we looked at something very interesting. If a patient has a positive AI, meaning the patient is considered to have low EF, a third of the times they would have an EF of less than 35. Another third of the times they would have an EF of between 35 to 50. So this is also an interesting echo, and we wouldn't really consider it a false positive. But a third of the case, patients have an EF of 50 or above, which is completely normal. On the other hand, if the patient's ECG is negative, 90% of them would have a normal ejection fraction. So we asked ourselves, what is the difference between these two groups of completely healthy patients? Some of them are considered positive and some of them are negative. And luckily, we have a lot of patients that came to Mayo year after year. So we were able to track their echocardiograms over the years. And we saw that if you have an abnormal ejection fraction based on your ECG, even if your EF by echo is 50, you are 5 times more likely to develop low EF in the future. Now, someone asked me, so it can see the future? And the answer is probably not. What we're seeing here is a subclinical disease. So the disease is already there, but it only manifested through the electrical signal and have not manifested to the mechanical features of the heart. And that kind of connects to the last questions that was asked about the hypertrophy, for example, right? There's 2 different modalities that can probably give us a lot of non-redundant information. So how do we use it in the real world? One of the first clinical trials that were done in the AI space was the EAGLE trial. In the EAGLE trial, instead of randomizing patients, we randomized clinicians. We took half of our general practitioners and gave them access to our ECG AI, and half of them did not get access to the AI ECG. We had about 22,000 patients, 300 family cares, a clinician, and the main purpose of this study was finding new low EF diagnosis. Now, again, these are the same population, the same patients, so the only reason to get a more new low EF diagnosis is if the model helped them find things that were missed by the other group in the controls. The way we presented it goes back to one of the questions earlier, is we only guided the clinicians to what the model thinks happens. So we said, we think there's a low ejection fraction, but you should still do what you want to do. We didn't order an echo. We didn't force them to order an echo. We did ask them later on if they have not done that, what was the reason. When we look at the indications for the ECG, you can see that most of them were fairly regular indications. Obviously, none of them was to find low ejection fraction. The primary findings of the study was, first we validated. We said, how well did the algorithm work? AUC was 0.92. As expected, it was still very nice to see it on a cohort that was tested after we trained the network, but this wasn't the main thing we were looking for. The main thing we were looking for is new low EF diagnosis. As then you can see here, in the group that had access to the AI, we had 32% increase in findings. So the doctors who used the AI found more patients. Then one of the critics were, well, maybe they're just sending so many more patients to an echo, so they're finding more more low EFs. And we did this study, and there was a non-significant difference between the echo done by the intervention group. So it didn't only find the patient, it probably also assured them who does not need an echocardiogram, which is a very important thing in such a scarce resource. Yeah. So one of the things we were looking at as well was delivering care at scale. Can we use the same ECG model but use a single lead instead of 12 lead? We started by using a medical single lead. So we took a stethoscope by ECHO that records both the heart sounds and the ECG as a single lead. And we went to patients that are in the echo lab waiting for an echo and recorded their ECG. We adapted our model to work on a single lead and tested it, and the AUC was again 0.9, finding that there's not a lot of difference or not a lot of data lost when you're using a single lead for ejection fraction alone. Then a group from the UK, unbeknown to us, did a parallel study using the same device. The company have licensed the algorithm from us, so they had access to our algorithm. This is a group from the UK. They ran the algorithm automatically when they did it for the patients. Also, before hospitalization for patients to detect heart failure, they had about 1,000 patients, and they found that the AUC was between 0.86 to 0.91, depends on where you place the stethoscope. So there are small differences between the leads of how you record it, but not very significant, and all of them had a very high AUC. And then we said, okay, we can do it from a single lead from a medical device. Can we do it from a gadget, like an Apple Watch? Many of us wear these Apple Watches. We record our ECG. We mostly get the heart rate. If a patient has atrial fibrillation and they catch it at that exact moment, they can find it. But we said, maybe we can do something better than that. But we weren't sure how are we going to get these signals. They are very different signals, as we'll see in a second. So we had to develop an infrastructure, recruit patients remotely, and transmit their data in a safe way. We then had to adapt our model from a 12 lead to a single lead. We did the whole study as a digital study. We recruited patients in a digital way by sending emails to all of Mayo patients with an iPhone. We asked them, do you have an Apple Watch? And if you have an Apple Watch, will you be willing to participate? If they answered yes to both questions, we send them a PTRAX consent form, so it's a digital consent form. And then if they consented, we send them a link to the app and they download the app. Once they download the app, they could upload the data, as we'll see in a minute. I mentioned earlier that we had a second aim to adapt our model. And you can ask yourself, why do you need to adapt it? It's just one lead. We can just cut the leads. The main problem is that Apple actually filters their signals very thoroughly to make it look good on the patient, to avoid movement and so on. We had a series of patients that had an Apple Watch and a 12 lead at the same time. And as you can see here, this is an example. The pacing spike is completely gone. The QRS is wider. The T wave is smoother. So there's a lot of information that is lost, even though the ECG are often look very similar. But we said if the AI is looking for these high-frequency signals, it will miss it. So we synthetically took our old ECGs, made them all look like an Apple Watch, retrained the model, got an AUC of 0.88, and tested it. We then asked patients to upload their data. Whenever a patient consented to the study, they upload all of their historical data. So the first day they joined, we might have dozens of ECGs. It's not only prospective. All of the ECGs were uploaded to the dashboard we're using for clinicians. All of the Mayo ECGs are going to an AI dashboard used by clinicians today, and we added a tab for people who have Apple Watch. So if you go to your physician, you felt unwell, and you are part of the study, you can show them their Apple Watch automatically. We stopped the study after about 5 months after we collected 2,400 patients and 125,000 ECGs, patients from 46 states and 11 countries. 56% were men, mean age was 53, but we have patients as young as 21 and as old as 92. We actually had a very interesting finding that patients used the app about 8 times, which matched our push notifications, but they use it more based on their age. So actually the older patients are the ones that kept contributing ECGs, which was very nice to see. Out of the 2,400 patients, 421 had a clinically indicated echo, roughly at the same time of the ECG within 30 days. And then we took all the ECG they had within 1 month and the closest one, just to test the differences. We also only use normal sinus rhythm ECG. Now, if you've read our original work, you've seen that there's really no reason to use only normal sinus rhythm on a 12 lead. It works very well on all rhythms. The reason we did that for the Apple Watch is that Apple only calls the signal normal sinus rhythm if it's a high quality signal. So if the quality is low, even though it's sinus rhythm, they just might not call it. So we used it as a QA method, the quality assurance method. 16 patients had an EF of 40 or less. In both methods, using a single ECG or all the ECGs on average, we got a very similar AUC, sensitivity and specificity of 81%. And just to summarize this part of the study on the low EF, we were able to collect patients from 46 states, 11 countries in 5 months, 125,000 ECGs, and apply our AI to Apple Watch. We're hoping that this will help us take the consumer device and make it a life-saving device. Another validation just published a couple of months ago in Nature Medicine as well is cardiomyopathy in pregnant women. One of the ways we see AI ECG making a difference in the world is in low-resource areas where it's very hard to get echo. Pericardium cardiomyopathy is specifically important because many of the symptoms women during late pregnancy have, hard time breathing, hard time walking up the stairs maybe, they're feeling unwell, are very similar to cardiomyopathy. And many of the times they would go to their physician and their physician would just say, oh, it's okay, after the delivery, hopefully you'll feel better. In Africa, in Nigeria specifically, maternal mortality is very, very high. And we saw this as an opportunity to send devices. We use the echo devices again. And we did a pragmatic randomized clinical trial. And we, again, assigned half of the patients to an AI arm or half of the patient to a non-AI arm. We did add a 12-lead ECG to the control group, but that was read by a human, right? So if there was any abnormal ECG, the human should have catched that. The intervention arm got both a 12-lead ECG and the echo device recording. We started with about 1,200 patients. Roughly 600 were in each arm during the study, randomized. And our main finding was that AI, in fact, improved detection of cardiomyopathy, up to twice the cases in the group that used AI in the same type of population. I mentioned it earlier, it was a very short study, but still, when we submitted it for review, the reviewers asked us, why didn't you stop the study earlier and gave everyone the AI? It's so useful. But we do hope that that would be the case in the future, because It also helped streamlining the analysis. You place the echo device on the chest, you get the results immediately, and it had clinical impact. So we saw a lot of the things that the AI can do. AI ECG can find things that humans cannot do. And one of the questions I keep getting asked is, okay, the model can see something I cannot. Why? What are we missing? And when the DoD in the US did a study, it actually shows that there's a very strong linear connection between the explainability to the accuracy of a model. As the model becomes more explainable, it also becomes less accurate. And there's a question of how do we want to use these models, because as probably many of you know, we use many medications that we don't know how they work. We just tested them well enough, so we say it's better to use them and not understand than not use them just because we don't understand. So I do think explainability is interesting, but I don't think it's something that has to be done for an FDA approval, for example, right? And that's something we're pushing very strongly to get trust using explainability, but not making it a mandatory thing. And there are problems with black box model that we know already. One of them is the model robustness, which we'll see an example in a second, why sometimes black box models are not as great for some tasks if you don't validate them well. Second thing is adversarial attacks. And also it might help with implementation. We do want clinicians to adapt these models, and we do think that if we adapt them and people understand them, maybe they can even learn from them, which might be the biggest breakthrough using AI. Going from a task that humans cannot do, but an AI can do, and go back and say, okay, maybe we can teach humans how to do it, and maybe we can learn during that process the basic mechanistic idea behind it, and maybe we can invent a new drug for it, right? If we detect what the exact mechanism is and use it as an exploratory method. Now, I mentioned that there are a few issues with models. So adversarial attacks are attacks that cause the model to act the opposite of what you would want it to do. There's a very famous example. A group from NYU published it in 2020 in Nature Medicine, where you take an ECG of a normal sinus rhythm ECG, very simple to see. You add it very, very small noise. You add them together. You get the blue line in the bottom. For the human eye, it looks exactly the same. But you run this ECG through an AI, and now the model says 100% atrial fibrillation. Not atrial fibrillation in NSR, atrial fibrillation now. So the model thinks this patient does have AF at the time. So this is one of the issues we can imagine. I don't think in medicine it will be a big thing, but it's something to look for. Second is bias. And I'm not talking about fairness, race. I'm talking about bias in the training data. There's a famous example from California. I gave the reference here, where they wanted to do pneumonia detection from X-ray. They took all the controls from one clinic, and they took all the patients from another clinic. They trained the model, they did internal validation, and they got an amazing accuracy of 100%. They tested it in practice, and the model had an AUC of 0.5. It was not better than a flip of a coin. Then they adapted some of the explainability method that we'll see in a minute, and they saw this thing. What the model was actually looking for is the L sign on the marker on the image. Because one clinic used one type of marker, and another clinic used a different type of marker, the model was just able to look at the marker and decide if it's a sick patient or a healthy patient. There was bias in the data in the form of that marker. And models are very good, so they take shortcuts. They take the simplest way, and they don't even look at the chest of the patient. So that's something we might want to look for. This is an example of improper validation during the building of the model, right? Once they validated completely in a different clinic, they saw why it didn't work well. Most methods are looking at activations. There are some models that do perturbations, where they change the input a little bit and see how it affects the model. But the majority of them just look at what drove the model to decide at each layer what's gradients, and then they just show it on a map and show what's there. There's many ways to do it using GradCam and so on. But these explain specific examples. You can only show for that specific example what drove the problem. It doesn't tell you what the model is looking at in general. And we asked ourselves, can we approximate AI using simpler methods in a similar way that we take linear processes and mimic complex nonlinear physical processes? And the way we've done it is, if you go back to the idea of machine learning versus deep learning, you know that we can take AI that learns the features from the data, but we can also take models that look through the human lens. So we take these QRS, P-wave, and so on, and then we said, okay, can we take a student model and train it to say, based on human-selected features, what would the AI say? We're not trying to predict the actual label, because then it would just be a simple model. We're trying to predict what the AI would say, even when the AI is wrong, to understand what's the connection between the two. For that, we took 50,000 ECGs. We ran them through human-selected feature extraction, where we extracted all the things that we think are important for humans. We then created a linear regression model between the human-selected features and the output of the model, and we created the linear explainability score, which is basically the R-square, how well we can explain the model output based on these features. And then you take these weights and biases of the linear regression, and you can see which features are mostly important. We then did the same with a student model that is nonlinear, and you can ask yourself, okay, but why would you try to explain a black box model using another black box model? And here we're not trying to explain the model, we're just trying to see what is the maximum explainability we can get through nonlinearity using human-selected features. And this gave us the upper limit to how well these features explain the models. When we look at the age estimation from ECG, it's another model, I didn't discuss it today, but we can predict age very well. If you take the features and using it in a nonlinear way, you can get the cardiac age with an AUC of 0.7. If you do it in a linear way, you can only get 0.57. So we explain a little bit less. That means that, A, we do not use enough features in this model to drive the cardiac age, but also the model is using them in a nonlinear way. That's why there's such a difference. It works almost the same for sex. And then we looked at zero-shot features. We thought to ourselves, okay, we know that the model is looking at the ECGs through the eyes of a human-selected features, but is the model actually using the same features, or we're just able to get there through a different route? So we took specific neurons in the neural network, and we tried to correlate them. What's called zero-shot means we didn't train the model. We just took the neurons as is, and we plotted correlations. And you see here that, for example, even though that there are zero correlation between your heart rate to your sex, women and men have the exact same heart rate ranges, the model was able to learn heart rate and average R interval very well, the same for maximum R amplitude. So the model is looking at the ECGs in a very similar way to how we're looking at it, even if you just poke specific features. We did it for all of the AI ECG features. As we can see here, it's kind of hard to see in this slide, but most of these features have very, very high representation in our model, which is interesting because the model never learned that it's an ECG. We just showed it a lot of it, yet it still found these native structures in it. The second thing is we said, okay, can we ask the model to generate an ECG with specific parameters? Can we ask it to say, give me an ECG of a patient that their ECG sex score will be 0.7, right? In our labels, we only have 0 and 1, but maybe we can do that. And we did something using generative models, specifically GANs, generative adversarial models. This model is looking at trying to mimic a human expert. We see a lot of this art that's done this way. And what we did is we added a pre-trained model, in our case, age or sex model. and we feed that as another input to the model, and then we get this feedback loop. So you're now saying, don't generate an ECG, generate an ECG with a specific score, and we optimize it during training, and we were able to get, can I play it, do you think? Yeah. So as you change the probability that you ask the model, you can see how the ECG changes in a continuous way. So we can now generate ECGs. We then said, can we use the same method for, and this is an example of the output. You can see that very, very small changes in the image create a very big difference in the output, but in a continuous way, right? In real life, it would be very hard to find two ECGs that are so similar to try to understand. So maybe by looking at this, we can understand which features are useful. We did the same for an X-ray. We took the open X-ray data set. We trained a sex model on it, and then we said, can we change the sex of the patient? And as you can see here, as the score changes, you actually see some features that are more common in women. You see breast tissue, you see the cage the difference, and so on. So it seems like AI model can be done in both qualitative and quantitative methods using the features and the generative models. It seems like our model are actually using a lot of human-selected features. So it's not that magical. It's just done it in a very, very efficient way. And we saw that we can get intuition just by generating examples. And maybe we can combine the two. We can create a lot of ECGs with specific features that we want and see how these correlate to human-selected features. And now, just for the last 5 minutes that I have left, I'll talk about AI for echocardiograms. We just heard from David a great presentation. Our concept was we know that we're going from many full transthoracic echocardiograms to point-of-care ultrasounds or POCUS, where we hope that by allowing untrained user, we might be able to scale to the bedside. We might be able to take technicians, nurses, anyone who can hold and use this. Maybe we can create more echocardiograms, but this will require AI for automatic analysis and guidance, right? How to do the echo correctly. One of the biggest challenges with AI for echo is that as opposed to an ECG, where the ECG is done almost the same way everywhere in the world, the user in the echocardiogram has a lot of impact, both of the quality of the signal and the ability to see whatever we need to see. One of the ways we started was estimating the left ventricular ejection fraction. And our objective was slightly different than what was presented before. We were looking at end-to-end deep learning frameworks that takes a 2D image clip and estimated the F without any prior segmentation because we wanted to avoid human labeling. As David said earlier, we prefer a lot of weak labels on very small amount of strong labels. And the problem, we do not have these segmentations available. What we do have are millions and millions of echocardiogram with a final ejection fraction. So what we did is we started by feeding those images. We did do some pre-processing, which we have not done in ECG. The reason we've done this pre-processing is we wanted to mask out anything that is not the echo frame itself. One of the biggest problems, one of the things we were worried about, is that most echoes contain an ECG, a single lead ECG. And for example, for hypertrophic cardiomyopathy, our ECG model with a single lead can detect a HCM with AUC of 0.96. So we said, if we just feed the ECG and the echo, we don't know if it's the ECG or the echo. So we're blanking it out and only feeding the echo. We're feeding to a CNN and getting the estimated label. We did understand very early on that also in addition to the issues of echo, we don't always know, or we don't have labels to which echo view we're looking at. We have many echo views, and we had to get people to classify these views for us And then we train a neural network to say which view are we looking at. The ability of the model to detect specific views was very, very high. This was done by Dr. Lee and Nasser, published last year, where we just classify automatically as the first step the views. Now that we have that views, we can select if we want all the views or we want to select different specific views, right? You can, depends on the disease, you can select if you want many types or not. And then we feed it to the model. We started by using EF, as I mentioned, and we added age regression. We started with a very small cohort of 6,500 patients. We did retrospective analysis of the data, but we also tested on a prospective cohort of patients with point-of-care ultrasound. And we had 100 patients that had both focus done by an expert and by a novice. So we'll see if the model helps us to bridge that gap. When we look at the point-of-care ultrasound, we see that there's a very, very strong fit between the EF of the patient done by a human and by the model. There's not a lot of difference between the model is closer to the estimate of the expert more than the novice, which probably means that the label of the expert was better. But as you can see here, the results are fairly good regardless, even though these models were never shown what's an ejection fraction. We just showed it a full echo, and we gave it a number to predict. We did the same for patient age. Here it was actually much better than the ECG age. The model was able to predict using a treadmill cohort that we had the patient age. And maybe for the last case, we're going back to the concept of doing what humans cannot do. So ejection fraction is very simple. But if you want to look at pulmonary hypertension, but use cath lab as the label, that's again something humans cannot do. We fed in 2D images. In this model, we actually focused on A4C only, or focused A4Cs. We trained it to a PH class based on the data from a cath lab. We took any patient that had an echo and then a cath lab the day before or in the next month, and we did an 80-10 and 10 split. There's also an AUC of 0.92, showing us that the model is able to look at pulmonary hypertension to a 2D A4C in a very strong way. And we are starting to see these great results using an end-to-end approach we feel is more scalable and very good when you don't need human labeling for AI. And maybe the summary in that we think this is a very strong concept which we can go from an AI ECG to say who needs a POCUS, then we apply the AI POCUS, and only then we diagnose. So we can take a single device, a point-of-care ultrasound, and find diseases in rural areas. In general, I think AI has the potential to change medicine, and we already see these changes in real life. We saw your very interesting papers showing that how we can change the outcomes of patients using AI. It's expanding to new fields, and I think, as we discussed many times today, it requires robust validations, hopefully in multi-sites, and most hopefully in international collaborations that will allow us to test these models and improve patients' life across the whole world. I want to thank you again for inviting me to speak, and I'll be happy to take any questions.
Thank you for that case inspired talk. Any question from our audience? Okay. Professor Lim, please.
Thank you very much. Very excellent talk. And I have two questions. And the first one is about the false positive management. Professor Chin Lin told us about the AI prediction for the cardiac age. Usually his friends wear Apple Watch, and when his friends drink, it becomes the cardiac age goes high, and when it exceeds a lot, they know that they should stop drinking. So I think the prediction is quite accurate. But for the false positive prediction, I don't know you mentioned, and we also see that it has a high heart ratio for the future cardiovascular adverse effect. But how we do the intervention for this special group, the first positive group? Have you done this, some intervention for this? And this is the first question. And I'm quite interested about the POCUS examiner. When I was a young doctor, I learned how to do the echocardiography. Maybe I need to perform 50 times, 50 patients to be the good, maybe not good, to be the okay echocardiographer examiner. But I don't know how about the criteria of novice examiner. They don't need anything because for as I mentioned, if they are only a teacher, they are not a doctor, they are not medical personnel. Can they do this by themselves, or they need to another special training for this? Thank you.
Yes, thank you for these questions. I think both of them are very, very important. The first one is, it almost brings us to the concept, like in cancer, of previvors, patients that you know that in very high likelihood will develop the disease, but you just don't know when, right? And the question is, what do you do with them? I think the current methods will be more close monitoring. So maybe you send them to an echo every year, or maybe you get them to another ECG in 6 months and then decide if things can change, right? You just have to look at them closer, because eventually I don't think you would treat anything before there's an actual disease, right? So I think continuous monitoring, adapting, and maybe, for example, if we do go to Apple Watch, then you get many, many points in time, and maybe you get a more accurate trend of the events, right? You can see the score and the probability of being better or worse change by the day. And then you up to a point and you say, okay, now I'll do an echo, now I'll get the diagnosis, and now we actually give you a device, for example. But it's an open field. We don't know. That's kind of the good things and bad things of having a black box AI, right? We don't know what's looking at yet. We just know that it works, so I think it's our obligation to use it. Not everyone agrees, but I think it's the ethical thing to do. The second thing about the echo, our novices were basically random people. They use the guidance systems that basically give them a green light, red light, and tells them with an arrow how to point it. I think on average, each of them did 10 echoes in their lifetime. And the concept is that maybe at some point, the same guidance system can be used even by the patient themselves. Just grab the echo, place it, you go to a Walmart or CVS or, I don't know, like a 7-Eleven, and just place it, and you get an image of the heart. The AI echo is smart enough to kind of cut and paste whatever it needs and give you the result, even if you don't know how to do the echo. I don't think it would lead to a final diagnosis, but it might tell us who needs an echo done by an expert, or who needs a full transthoracic echo. But again, I think AI, the biggest power it will have is to help us scale, right? Take a physician or take a resident and help it work like someone who's more expert than them, or do more than they can do without AI.
Please.
Thank you for your great talk. I'm so impressive about you mentioned the predicting power of the AI ECG for future low ejection fraction. It's just like a fortune teller. It can, you can predict a human future's destiny. So I'm so curious about, you just mentioned, so what did the AI see but the human did not see? I think that's the key point. And my question is there any study currently can decipher such a mystery? You just mentioned we can learn from the AI. Is there any data or any study try to explain why AI has such a power that we can learn from them?
Yeah, so Great question. We did publish the work I've shown on the explainability, and we do analyze these AI ECG models through these features. It has predictive power, but as we add on the features, it becomes harder and harder to make sense of it. So if you use just the QRS width, you get about an AUC of 0.7. How wide is the QRS? Then you add another feature, the PR interval, or then you get more and more, but then it becomes harder for the human to do it. We have not found a single very, very strong feature that just tell you, if you look at this piece, you would get the exact reason. But we hope that if we generate enough, and that's an active area of research in my lab, we'll generate enough of them, maybe we can simplify it and say, okay, let's take an existing ECG and make it look more like low EF. Maybe we'll notice the differences.
So probably in the near future, from the learning from the AI, we can tell that just like you mentioned, let's say the P wave duration, the PR segment, the QRS morphology, or ST segment, something like that, can predict the future event or future ejection version. So if maybe next year when you can publish a paper to tell us that AI say something is more important that we don't know, I think that will be a very fantastic finding.
Yeah, I think that's a very innovative idea. Thank you.
Okay, any other question from our audience? I want to ask a question to I have a lot of about you developed the AI model from your hospital data, for example, 12-lead ECG, and apply it to the other device, for example, stethoscope or Apple Watch, and using your hospital echocardiogram to train the model and apply it to the point of care device. So can you share your experience how to use this how to use your hospital's data and to apply the model to the other device? Because in our experience, we face the significant performance decreased.
Yeah, I think that's a real problem because in real life, we do not have a lot of non-medical data for training, right? Most of our data is very high quality. We try to translate it to an Apple Watch, you lose a lot. The only way we find that works very well is by augmenting the data to make it like it's for example, Apple Watch. We filter it very heavily, so we make the problem harder. I think one other task that we can do is maybe build it as a foundational model where we show the same ECG in multiple representations, sometimes through heavily filtered, sometimes through 12 leads, sometimes one lead, sometimes more than one lead. But I think at some point we might have to collect some data to at least validate it or fine-tune it, because the Apple Watch study I did, for example, was using 12 lead to train, but you have to test it on real data, otherwise you don't really know how well it works.
So you still need some sample to fine-tune the model, or you just need something for directly use the original model?
Yeah, so we took the original model, and then we took the same signals that we used. We fed them through very, very heavy filters to make it look worse, like an Apple Watch, and then we fine-tuned the same model. So the model was shifting from a single lead, from a high-quality one to a single lead to a low-quality. For some devices, we also applied more strict criteria. For example, the stethoscope. It doesn't matter what side you put it on, you still get an ECG, but you get it flipped sometimes. So we fed it flipped and unflipped and averaged the score, for example, to make sure that no matter what's the polarity, you'll get the exact same score all the time.
Thank you for sharing experience. Any other question from our audience? Okay, maybe we can.
Thank you, Professor Attia and Professor Lin. Now we would like to invite our moderator, Professor Chin Lin, to present a certificate of appreciation. Before we proceed to the coffee break, we would like to kindly ask everyone to gather on the left side of the room. We would like to take another group photo. Thank you. We'll take a short coffee break. Please feel free to enjoy the refreshments outside, and we'll resume at 3:20 p.m. Okay, 3:30 p.m. Ladies and gentlemen, the symposium will resume in 3 minutes. Please take your seats and be ready to start. Thank you for your cooperation. Ladies and gentlemen, the symposium will resume in 1 minute. Please take your seats and be ready to start. Thank you for your cooperation. Okay, let's welcome our next speaker, Professor Qin-Shen Lin. And moderating this session will be Professor Rongshen Jiang. Let's give him a big applause.
Oh, thank you so much for this wonderful talk, previous one. And there is always a saying, well, if you want to make a conference become an excellent conference, there are 3 key factors. Number 1, good people. So like you, it's good people make it a good conference. Number 2, good meal, which is tonight. It's good food. We can enjoy the good food tonight. And the 3rd, guess what? It's good presentation, which means gotta be a good talk. And I'm very happy to be here. I came from National Cheng Kung University Hospital, and I'm a computer scientist. I know Dr. Lin and Professor Lin for many years. The reason I wear this special pilot, I'm not pilot, airport pilot, but I like this kind of jacket. And this is, I obtained this 3 years ago. I know him many years. He finally said, one day he said, well, I'm going to give you a special gift, and which is this. This is the ROC Air Force. You can see this. So that is why I wear this in front of you to show our friendship. Okay, thank you. And our next speaker is Dr. Jin-Seng Lin. I know him. I know he's a very good and excellent cardiologist. And not to mention about his team is a huge team, more than 10 or I guess probably 20 professionals in his team as well. And he's not working in the cardiologist field. and he has been working on AI-related research in the cardiology health. And he's also, his team member, they are also work very good and very experienced people in CCD data and a lot of clinical trial. I'm sure today he will focus on the research topic of the AI and ECG signal, how they make this from the idea to reality. I know if you want to make this thing as just an idea, AI model prediction, that is easy. But if you want to make that become clinical trial and also make a good people, they trust this AI model, that's a different story. I'm sure Dr. Lin will be very happy to show you his experience in the past several years, not to mention about published paper in Nature Medicine and several very outstanding and distinguished journal there. And right now, let's welcome, I will give you Dr. Jinseng Lin, and his talk will be their clinical trial of AI and ECG in Trial Service General Hospital. Let's welcome Dr. Lin.
Thank you, Mr. Zhang, and great audience. It's really my great honor to have this talk. And in front of the masters like you, so I just want to, say it's difficult to initiate this kind of project. RTR also asked me how do I enter the AI field. I think for clinical doctor, it's really difficult. And today I just want to share that we are multidisciplinary collaborations. And fortunately, we have this opportunity that we can conduct this study and a trial in our hospital. We get a support from our boss, from National Defense Department and the Medical Bureau, and not only technical support, but also the foundation funding support. It's difficult. And we also get the support from our hospital for all the environment, and we also get a support from our division of cardiology and all the people, technicians. They help us to conduct the clinical trial. I think from the Zaki and David talk, we know that it is practical to implement the AI, not only ECG, but also the echocardiography in clinical practice. But we need to prove its effectiveness, and we also need to reduce the bias and to enhance the generalizability and try to persuade our government to buy in this AI product. And this is what I currently are working on this. So this is our outline. And I think you guys all know that maybe we can apply the future AI technology to monitor the fetal heartbeat. But usually when we apply it in clinical practice, maybe it is not so practical. Yeah. And in the real world, when we compare, when we train the AI, maybe we need the echocardiography result, and we have the ECG result. And then we hope to know the echocardiography result from the ECG. So we do a lot of training, as you guys already know that Zaki and David, they have already very excellent results. They can find several promising findings from the AI ECG to detect such as atrial fibrillation or such as many valvular heart disease. But is it really effective in clinical situation? So that's why we need to conduct the clinical trial. So when we apply this AI product, AI ECG product to clinical, we always hope that we can apply this tool to have a large-scale screening. So now we apply it in the medical, in our hospital, and also apply it in the remote area, and also in island. Usually, for this kind of area, there are lack of medical resources. But if we can apply this kind of system to have a large-scale screening, maybe we can identify the high-risk patient, and then we can ask them to seek for medical care, and then we can reduce our medical cost. That's what we are doing now. So for the AI-enabled screening test, I think the AI alert alarm to a physician, and also now we are doing alarm to patient is quite important. We use the electrical system, we can alarm to a physician. But as David mentioned, maybe for the high-risk population, we can also use the phone call to alert the high-risk patient and then do the confirmatory test. So that's maybe we can change the clinical outcome, and we can identify the high-risk patient. So in our hospital now, from the HIS and automatic AI warning system, we can easily get the message of the high-risk population. But for chronic illness, usually we identify the high-risk patient, and from the informed consent, we can easily call them back, try to confirm the probability and the disease of the patient. So currently, we have conducted and finished some trials in our hospital. I think, as you guys know, that we conduct the AI ECG for in-hospital mortality prediction. And it's quite interesting that I think in 2020, we all know that the AI ECG could predict the 1 year mortality. But when I reproduced this study in our hospital, fortunately, we found that the AI ECG performed much well in 7 days mortality. So we just talking about this finding, and we think that it would be great if we apply this system in the hospital environment, and then we can see if this simple modality and the simple alert could reduce the risk of mortality. And fortunately, we found that when we send a high risk for mortality to the physician, the physician is very nervous about this message, because they say that your patient will die. The probability is very high. So usually they call me what I need to do next. So then I will give them a list. Maybe you will have an intensive monitor, and you have to do a lot of electric exam, echocardiographic exam. And maybe all the doctor agree that once the doctor know that your patient will die, they will monitor, they will watch the patient more frequently, and they will explain the worst prognosis to a patient's family, just in case something happened. They have prepared it well. So we conduct this study for 1 year, and then we found that application of this kind of system could significantly reduce the high-risk population for 30% for the high-risk population. Not only cardiac death, but also non-cardiac death. As we know that in patients with multiple organ dysfunction, although they may have some medical problem, that sepsis or bleeding, they have some change, damage in heart, leading to cardiac dysfunction. So I think from this result, the AI ECG could also detect the signal. And this study, I think David knows it very well. I will also conduct this for the STEMI detection. And we have already validated that we have this algorithm
to detect STEMI in our hospital, and we are able to identify the STEMI patient and to do the further study. So now in our hospital, once the patient enter our hospital, they receive an ECG. The AI will analyze it first and send the warning message to the on-duty cardiologist and also the emergent physician and also the on-duty the fellow, chief resident, etc. So we found that application of this system significantly reduced the door-to-balloon time for 9 minutes. I think during the lunch, we discussed it about the real effect of this system on the mortality. But we have already calculated it. We need a much more patient to prove its effect on the mortality. And we also conduct this clinical trial for the atrial fibrillation treatment. I think for cardiologists, it is easy to manage a patient with atrial fibrillation. Maybe for some high fast score, we'll prescribe some anti-arrhythmia medication and also NOAC for stroke prevention. But for the lung cardiologist, clinical physician, they don't know how to manage of this kind of disease. And usually when they ignore the ECG. And for some physician, maybe they will send this patient to the cardiologist. But most of them, they don't know how to do it. So we also conduct this study, and then the in charge, the physician, can receive the message, and then we can tell them how to do that. Usually, even they know this patient has atrial fibrillation, they don't prescribe the NOAC, but they will refer this patient to the cardiologist. But it's good. I mean, so the patient will see the CV doctor, and they will receive the adequate treatment. So we also prove that application of this study enhance the increased use of NOAC and reduce the gap between cardiologist and the lung cardiologist. And this is the first study that we have performed to evaluate the potassium level by ECG. So we also did a clinical trial to prove if it is effective to apply this study to follow dyschemia management. And we proved that application of this study, the AI ECG could enhance the management of dyschemia by clinical doctor. So now this work is currently under review in a paper, and we also performed the clinical trial for the low ejection fraction detection. I think Zaki know it quite well. And so currently, we have already finished 5 clinical trials, and we have another 5 clinical trials which is ongoing. And we just conduct and apply this, our AI ECG system, to other medical centers in Taiwan. So we hope to conduct a multi-center study to have a randomized control trial. And I think it's good that we really thank for our government. They support us to do this multi-sample randomized control trial. And maybe Debbie and Zeki know that it's difficult to do this kind of this. And because we always need the informed consent, and we always need a lot of proof to do this. And we have a lot of barrier between different hospitals. So now in our government, we have the Center of external validation, we also have the center for AI inference. So that we can do it much easier than before. So now in our hospital, we hope to establish a friendly clinical trial environment. Now, when we do this, we are military medical center, the only one military medical center in Taiwan. But we have 14 medical hospital in Taiwan. So our both the medical bureau, National Defense Medical Bureau, has unify all the medical hospital, and we have the unified the ECG format. And we also collaborate with our other hospitals, such as Chengong Hospital, the Far East Hospital, and the Taipei system. All these different systems, we collaborate together, and then we can get the heterogeneous data to perform this clinical trial well. So now in our system, although we have already all the data in format, we still need to collaborate with other systems. And we use the file format, and then maybe we can do further feeder learning, etc. We can have the unified format with other system data. And we can also get the data from the NHRID, which is the biggest data center regarding the health in Taiwan. So I think to have the data, to have the unified format data is everything. So now we are just working on it, and we have this kind of data. We can easily conduct the multi-center study. And we also hope to do this. We hope to get the e-consent from every patient who visit our hospital. Once the patient visits our hospital, maybe we can easily use the e-consent to get the authority from the patient. And then we can put it in the same format, then we can do the clinical trial. So for this kind of issue, we are currently working on, and we hope that I think it's now we are doing, and then we hope to finish it maybe at the beginning of next year. We can get it done. Yeah. So also when we get now, actually now we only have the paper sign, but maybe in the beginning of next year we can have the e-consent, so we can easily get the paper. But even for the paper site, we can get, I think should be 40,000 patient informed consent. Yeah. So for e-consent, I think maybe larger. So I think that then if we can easily get this informed consent, we can easily do the randomized control trial for our patient. And then we, for the high-risk population, we can get the AI alert, not only to the physician, but also to the doctor, but also to the patient. So in the hospital, we have working on it for, I think, more than 7 months. 7 software engineering to create the app. And then we have all the, we hope to include all the patient population and to do it. So it could reduce the cost of informed consent. I think in Taiwan, the cost to get the informed consent is much cheaper than in US. Yeah, usually the NT dollars to US dollar is 1 to 30, I think. Yeah, but I think the same amount of money equal to also in US dollars when we need to get informed consent in US. So it is cheaper. And it also allows us to have the cross-system hospital to upload the data. If you have the fire data and you have a smile on fire, we can have the fast AI implementation. And we can also compatible with the government app. So I just have a short talk, and what I mentioned is AI impact on clinical practice should be evaluated and validated by clinical trial. And now we have finished 5 randomized control trial of AI ECG, and we have another 6 randomized control trial ongoing. And I think the friendly clinical trial environment is critical. And we need to get the support from many, many people, from our boss, from our government, from our system. And we need to deal with the technician very well. And because if they cannot do the very good service, it's difficult. Because the customer, the patient satisfaction is always the most important. So we need to explain it very well. So for all these kind of factors, maybe we can do it very well. And finally, I really want to thank our hospital, our university, and also the National Defense Medical Bureau for their funding and guidance. Thank you.
So much. And thank you for Professor Lin's wonderful talk. I'm sure we can take quick questions. If you have any question, please raise your hand and we can have a quick question. I might be to take this. Oh, yes. Hey. Okay, David, please. Hey, David.
Dr. Lin, this is a fantastic talk, and it's incredible the amount of infrastructure and resources needed to do this. My question to you is, for you and as well as the group, how do you decide which algorithms to implement, right? There's an infinite number of possible choices. How do you decide kind of which trials to conduct and what are most important to you and to your hospital?
Oh, yeah, I think that is decided by clinical physician. Usually we have a team to discuss about this. And from the very beginning, we just use it according to the feeling. But we discuss it. I think many my team members here, and some of them are EP, cardiologists. Some of them are interventional cardiologists. And then usually they, when we announce and proposal, and then they get into discussion. And then we try to figure out how it works. So I think, the Professor Zhang says the right thing, that we, in our team, we have more than 12 young cardiologists. Some of them are EP, some of them expert are echocardiography, and some are EP cardiologists. And then they will know the specific interest on it. Yeah, so maybe two of them handle the one project, and they can discuss it. Thank you.
Okay, thank you so much. Hey, Nick, if you don't have one, feel free.
Thank you, Professor Lin. Amazing talk. Very exciting to learn about how you're trying to do the consent easier. In the one multi-site trial, have you seen differences between the patients, the results among sites, or was it working well among different sites?
Oh, from one, our hospital compare with
other hospitals.
Sorry, actually, now we only get the paper informed consent from our hospital. But what we are working now is we collaborate with other hospital. And maybe I can answer the question next June or next May. I can answer it. Sorry. Thank you.
Okay, so as soon as the data and everything is available, and then you can ask that question to public. Thank you so much. I think time's up. And again, ladies and gentlemen, let's thank you, Professor Lin, give us this wonderful talk. Thank you.
Thank you. Thank you.
And now I think just give me a minute here. And I'm very honored to be here to present this to you and our great speakers. Thank you.
Now, let's give another round of applause to welcome our next speaker, Professor Qin Lin. And moderating this session will be Professor Wenhui Fan. Yu Cao.
That's fine. Yes. Okay. I'm Yu Cao. Hello, everyone. It is my great pleasure to introduce Professor Qin Lin. Let me briefly introduce Professor Qin Lin. Yeah, he received his PhD degree from 2016, right? Only 8 years from now. Yeah. During these 8 years, he has made remarkable achievements. Yeah, currently he was AIoT officer, a CTO officer of AIoT in Tri-Service General Hospital, and currently he's associate professor, School of Medicine, National Defense Medical Center, and director of AI Lab, Digital Medical Center, Tri-Service General Hospital. Okay, yeah, I've known Dr. Lin for several years. At the first time, I was quite impressed by his positive personality and optimistic attitude. And after I know him more, I'm very impressed. I'm more impressed by his very rigorous research attitude and a very strong research background. And you can see he has published many impactful papers, including Nature Medicine, right? And it is like a 1 out of 268 ranking, right? And also New England Journal. Yeah, that is a remarkable achievement. Okay, let us join me to welcome Professor Qin Lin's talk.
Thank you. Thank you for my moderator's introduction. Today, my talk, I want to talk about our future development strategy in our hospital. My talk title is Foundation Model in Future Healthcare. Okay. The scientific discovery in the age of AI is changed. For example, in the past, if we want to find a new compound to treat some disease, we need the high throughput process to screen a lot of compound and try a lot of compound combination. But if we can use the AI model, maybe we can reduce the search space, and we can get the more efficient compound combination to treat a disease. In our study, we want to understand how to use a current examination to predict the other disease. For example, using ECG to predict low ejection fraction, or using ECG to predict paroxysmal atrial fibrillation, using any examination to predict any disease. Now, if we want to do this work in the past, we need to do a lot of medical research, but now we only need to train an AI model. An AI model will tell us the accuracy, the correlation between the disease and the examination. If AI tell us the AUC is 0.6, okay, we can put it to the trash. And if they tell us the AUC achieved 90%, we can select it as the new medical application. How to use ECG? I currently do a lot of AI ECG work, and in the past few years, Zaki and his team do a lot of AI ECG work and inspire us. For example, using AI ECG to predict low ejection fraction that is not recorded in the textbook before, and using AI ECG to predict paroxysmal atrial fibrillation. Also, it is not recorded in the textbook before. And after a few years, they write a review article and show the AI ECG can predict a lot of new disease beyond the human knowledge. And the next step is how to change the practice. The answer is opportunistic screening. Also, the luckiest team has a good example to use AI ECG in the primary care setting. And if a patient receives an ECG and the AI identify it as a high-risk patient, they will send a message to send an email to the doctor, and the doctor may arrange the echocardiogram to them. So that is the good example how to use AI model to change the clinical practice. In our experience, we also use AI ECG to reduce the in-hospital mortality. That is a paper our director Lin just mentioned. Okay, we also use the same concept to send the high-risk alert to the doctor, and the doctor will arrange more intensive care or continuous monitoring or more examination to the patient. And finally, we found the high-risk, the mortality event can be changed by the AI ECG intervention. But when we want to use AI ECG to predict more diseases beyond, and that this disease may be not recorded in the textbook, we have a limitation. At least the limitation is sample size. For example, if we want to, in our hospital, we only have less than 300 hypertrophy cardiomyopathy cases in our hospital. And there are a lot of rare disease in our hospital. We do not have enough cases to train the AI model. If we have enough cases to train the AI model, everything will be changed. For example, Zaki's team has a lot of patients with hypertrophy cardiomyopathy, so they can train an AI model achieved 96% AUC, but in our site we only the AUC only achieved about 80%. So that is a lot of difference because we do not have enough sample. So how to resolve the limitation? The answer is a pre-training process. In the past few years, natural language process task is very difficult. For example, I guess you have some experience to use Siri in using your iPhone, and I know that is not very smart because they may use the last generations. They may use the traditional method to train the AI model. But now ChatGPT is very smart, so the answer is how to train the ChatGPT. And we all understand the question and answer pair is the sample size of question and answer pair is very small. So the magic of ChatGPT is the two-step training process. The first process is to do a pre-training process. For example, mask some text in the internet text, free text description, and the large language model will fill it. And after this pre-training process, they can do the fine-tuning process using the using some sample of question and answer pair. Now we all understand we only need a small number of question and answer pair, and we can do the we can train a good large language model. And so that is the magic of ChatGPT. We need a foundation model to train as the basis, and this is the example how to apply foundation model in AI ECG research. This work published by Mount Sinai Hospital, and they train a foundation model by mask training process, like the language process. They use they mask the ECG image and let the AI model feel the image, and they use it as a pre-trained model, and we can find the most important result here. If they do not use the pre-training process, the performance to predict the low ejection fraction using less sample is not very well. But using pre-training method with fine-tuning process, even they used only 1% sample in the training set, they still can get an AUC about 90%. So that is the foundation. That is the magic of foundation model. But in the language, in the last I mentioned, the language task or the ECG foundation model developed by Mount Sinai Hospital, they all used the unsupervised learning to train the foundation model. But now we know maybe we can train the foundation model by more efficient method, such as CLIP model. The full name of CLIP is Contractive Language Image Pre-training process. And here is the summary of CLIP. We need the image and the description pair, and the model will understand which description is belong to the corresponding image. And I understand it has the future prediction ability. For example, using a prompt, a photo of something, and we can change the something to a dog, cat, car, and so on, and the model will understand which description is more likely to the image. Here is the zero-shot prediction process. And I know our distinguished speaker, David, you published a paper with using the echocardiogram and the free text report as the pre-training resources, and you train a model you train a model using the same method, and now I understand you can directly predict the low ejection fraction, the ejection fraction value by zero-shot method. I think that is an impressive work, but in my work, I think that is there is a more important use method for the CLIP model. This is the figure in the CLIP paper. The figure 2, you can see the CLIP method has more efficient compared to the other method to train the AI model. And here is the figure 6 of the CLIP model paper. You can see if we have 4 sample per labels, we can achieve the same performance compared to the zero-shot prediction. And if we can get more sample, we can get a higher accuracy. So we want to apply the CLIP model for future learning because if you want to let one product to get the FDA or TFDA approval, you still need hundreds of samples or thousands of samples to prove that. So I think the future learning is more important in medical field. Here is our experiment setting. You can see we use the chest X-ray and the corresponding chest X report to train the AI model and fix the vision transformer part, and using linear probing to fine-tune the prediction model. And here is our result. For example, using only 128 cases and 384 controls, we can achieve the average AUC to 90%. If we use the traditional convolutional neural network to train the model, we need 1 million samples to achieve the similar performance. And another important finding is we used this model to predict the label from echocardiographic data. And because radiologists may mention some radiological label in their report, but they cannot describe the ejection fraction value in the radiological report. So if this method also can apply to the other domain label, that is very important. We want to prove that, and you still can see only 500 sample we can achieve the average AUC compared to similar performance compared to the traditional convolutional neural network training by the 4 sample. And now we want to train a foundation model using multimodality data, because if we have this model, the model can integrate a lot of examination information and predict more precise. For example, now we cannot use ECG or chest X-ray to predict cancer, but cancer is very important. So if we can integrate more information into one model, maybe we can predict cancer with a high accuracy. So how to train the multimodality foundation model? In our concept, each patient has a lot of electronic healthy record, but if a cardiologist see your patient, you only see a limited part of electronic healthy record, and the other physician only see a part of electronic healthy record. But these two physicians can understand the patient status only using the limited part of electronic healthy record. So we can randomly sample one patient electronic healthy record to the first AI model, and randomly sampled another part of electronic health record to the second AI model. And we want to train the AI to learn how to present the high-level feature using the different electronic health record, but the embedding is very close. That we will do the contrastive learning process, and now we all understand the foundation. To train a foundation model need a lot of sample. So now we need to call for collaboration. Here is my vision of the next generation healthcare system. After people visit to the hospital, the physician will identify the people with severe disease and do the intervention to them. And the physician will record their data into the database, and AI will reuse the data to identify some people with mild to moderate disease or early stage disease. And that is why we want to establish a foundation model, because foundation model can fully use all data in the electronic healthy record and to do the better prediction for the patient. Here is my take-home message. First, I think the AI is very useful to discover more medical knowledge. And we can use this method to identify more diseases and more under-diagnosis condition. Second, I think foundation model is very important. If we can finish this project, it can be used for diagnostic support or prognosis prediction and treatment recommendation. Third, our ongoing future plan is a multi-modality foundation model. And I think the next generation healthcare system will use AI to help to identify more patients with early stage or mild disease, and the healthy care system will become more efficient. Thank you for your listening.
Okay, thank you very much for the great talk. Yeah, so any questions from the audience? All right, so, okay, please go ahead.
Thank you.
Really great presentation, Shin. I think you really touched a lot of the really interesting points about the foundational models. Mm-hmm. It's more of a comment than a question. I think it's something that to really do well, we should do together. So I hope, as a group, we can do that, because the amount of variability in the data is also important. Mm-hmm. I might ask a little question about the images. Have you find that when you use pre-trained models from the internet and fine-tune them, do you get better results, or only if it comes from medical data?
I think we still need to use the opening large language model, because they understand the language concept, and a lot of medical recorded is recorded by language. So we still need to use the Llama or other large language model as the pre-training resources. But we still need a lot of electronic healthy record to train, because there is a lot of difference between electronic healthy record and the internet data. And also the medical image is only available in the hospital database. For the opening data, there is a limited number for training. Thank you.
Fantastic question or presentation. Going off of a similar idea, we previously said that even point-of-care ultrasound is very different from traditional echo. The notes across different healthcare systems are so different, at least in the United States, even from hospital A to hospital B. How does it look like in Taiwan? And how would you imagine a collaboration when the text part is so variable?
I think that is a big problem. We need some pre-process method to standardize all data from diverse institutes. But if we can, if we can integrate all hospitals in the world, I think that is not a problem. So maybe we can collaborate with more and more groups, and after we have a lot of data and very, very diverse data, maybe the model can directly overcome this problem. Thank you for your comment.
Okay, thank you very much. So I think you can talk to Dr. Ding Qing like offline. Yeah, so let's give a big hand to Professor Ding Qing again. Thank you.
Last, we would like to invite our last speaker, Professor Yongchun Zhang. And moderating this session will be Professor Wenhui Fan. Please join me in giving an applause.
Everyone, I'm Wenhui Fan from Tri-Service General Hospital. It's a great honor to be here to introduce Dr. Zhang Yongchun. We know Professor Zhang is a leading expert in AI and natural language processing and machine learning. Dr. Zhang now is a professor at the Taipei Medical University and serves as the Deputy Chief Data Officer and the Deputy Director at the university's AI in Medicine Research Center. Dr. Zhang's work bridges cutting-edge AI technology and healthcare, focusing on groundbreaking innovations such as AI-driven clinical decision support tools, predicting patient outcomes, and analyzing complex healthcare data. Today, Dr. Zhang will deliver a talk titled, "The Future is Here, Unlocking the Potential of Clinical Data with Large Language Models." Please join me in welcome these distinguished speakers.
Okay, thank you very much. And yeah, the title is "The Future is Here," and the talk is about a large language model, okay? And yeah, I'm Yongchun Zhang. You can just call me Peter. And yeah, I'm an IT guy, so my background is computer science. So my research interesting is, yeah, definitely is natural language processing, right? So the first slides, I just wanted to show you how difficult the NLP in clinical, okay? As you can see here, sorry. As you can see here, the first one is the report in the emergency department. So I cannot point out that. All right. No. Oh, okay. Okay. This one. Okay. This one is from the emergency department. Okay. As you can see here, the text here is mixed language. It contains English and the Mandarin Chinese and the symbol as well. Okay? And very, very short. Okay, it's a short text. And how about the procedure report here for the lung cancer and for the breast cancer? The procedure report is longer than the text in the emergency department. So it's very difficult for natural language processing. Okay, the slides I wanted to show you the trend of the SOTA method in NLP. Okay, as we can know, the large language model become larger and larger, but another direction is small language model. So here I point out 5 leading small language model maybe from the Meta Llama 3, or Microsoft 5.3, or Google Gemma. Okay, why I pointed out the small language model? Because the privacy issue of the clinical data. So we cannot use the online solution, such as the ChatGPT. So we need to train our own model offline. All right. And if we want to develop our own model, what challenge we need to face? Okay. First of all is the data governance. So the data type is very diverse. Maybe the text data is from image. So we need to use the OCR technique to fetch the text information from the image. Another, maybe the text information from the speech, from the dialogue. Okay, so we need to use the voice-to-text model to convert the speech information to text. And then how to share the data safely, okay? And next is, as I mentioned before, the data is mixed language in Taiwan. Moreover, the data is small, so not the big data. Okay, another challenge is the data annotation. Okay, the data annotation in clinical is the high cost, all right? And the last is data imbalanced and the model explanation. Okay, this is the challenge in clinical NLP we need to face. Okay, the first application I want to share is we use the natural language processing technique for the lung cancer treatment. Okay, so here I pointed out 4 key points, actually the 4 key challenges in the lung cancer treatment. So what I wanted to do is, the first part is use the NLP technique to speed out the report generation, okay? And the second is about the summary generation, okay? Here we wanted to help doctor quickly catch the important information from the pathology report, okay? The last part is about the treatment. Okay, we use the natural language processing technique to suggest the drug and help the doctor and the patient to do the clinical trial matching. Okay, let's talk about the detail. All right, the first is two-word atomic radiology report generation. Okay, here we use a computer vision model to extract, okay, here is a nodule. Okay, to extract, to sec, here is the nodule, and fetch out the information of the image to the, our natural language model. And the model will predict a semantic label from the image, and then use the feature, fit the feature to the report generation model. And as you can see here, the generated prototype of the text report here. In the first case, it's very serious case. You can see that the report described there is a 8.4 mm solid nodule. And also, according to the lung rate version 1.1, the score is 4A. It's very serious. So the malignant probability is very high. It's about 100%, and suggests closely follow up. And the second one is not a very serious one. So as you can see here, the texture is pure GGO nodule compared to the one is solid nodule. So the score is 2. Okay, so malignant probability is lower than the first one. Okay, the research result is published in 2022 before ChatGPT. Why I say that? Because nowadays, generate report is very easy. Use the large language model. So as you can see here, the prototype content is very similar to a prompt. So we'll use the offline large language model. Actually, it's Vacuna. Yeah, Vacuna. And use the prompt we generate to ask the Vacuna to generate a report for the radiology. Okay, so as you can see, the right-hand side, the new generation result is better than previous one. All right, for the second, third, and fourth part, I wanted to show you a video, a short video. And this technique, we very honored won the last year's FinTech Awards. Let's watch the video.
Taipei Medical University employs generative deep learning for the prediction of late-stage lung cancer drug efficacy and prognosis, along with the screening of global clinical trials. Among the top cancers in Taiwan, lung cancer is the leading cause of death, with 70% of patients already in the terminal stage when diagnosed. But thanks to breakthrough AI technology, medical decisions can be made in just 5 seconds based on pathology reports. These decisions include drug selection and new lung cancer clinical trial screening that aim to improve survival rates. The interdisciplinary research team at Taipei Medical University are pioneers in NLP and generative AI technology. We employ multimodal prediction methods in order to provide optimal drug combinations and relevant clinical trials in only 5 seconds. By doing so, this reduces the treatment waiting time and can bring major breakthroughs for late-stage lung cancer treatment. We use state-of-the-art NLP models like BERT and generative GPT technologies that are trained on over 20,000 lung cancer pathology reports. Our developed model can quickly extract up to 52 important features and achieve an F1 score performance of nearly 90% in a 4,000 data point cross-validation. This leads current international benchmarks. These extracted features serve as GPT prompts to generate high-quality summaries. The summaries make crucial information easy to understand while ensuring the safety and privacy of sensitive medical data. This forward-looking technology is awaiting US and Taiwan patents. Moreover, our method further links treatment efficacy to survival data from over 5,000 lung cancer patients and uses generative GPT technology to generate the most effective drug treatment options for the best prognosis. This result is like consulting dozens of experts who have read thousands of pathology reports. The method streamlines shared decision-making between doctors and patients. For late-stage lung cancer patients, it will also create the option of using new drugs in clinical trials. Our NLP model can automatically and accurately match global trials for new drugs. Put more simply, once the pathology reports are out, our BERT GPT algorithm not only offers prognosis and medication options, but also matches relevant global clinical trials, which will enable rapid shared decision-making and expanding treatment possibilities. This product is currently undergoing clinical trial with...
Okay, since the time is limited, sorry. Yeah, let's quickly talk about the architecture of the method, okay? So once we have the patient's pathology report, the first model can illustrate about 50 key features, clinical features for the lung cancer treatment from the pathology report. And then we use the large language model to help us to generate the summary, all right? And then once we can illustrate the key feature from the patient, and then we can use the key feature to represent the patient. And then we have the patient data bank. We can search out what kind of patient is similar to the current patient. Okay, so we can refer the past patient's survival and the drug, right? And the last part is about the clinical trial matching. And we use the very similar technique to search out which clinical trial site is suitable for the patient. Okay, this is the whole architecture, all right? And in order to make the model more practical, so we developed an app. Okay, so we can just take a photo and then we can use the service like this. So here, because we take the photo, we need to use the OCR technique to extract the text information. All right, as you can see here, the report summary is generated by the our small language model. Okay, the next one is use the natural language processing for emergency department. Okay, so here, as you can see here, is the procedure of the emergency department. Okay. Okay, the idea is that we want to use only 20 minutes information we can get, including the vital sign and the clinical narrative, to predict the outcome, to predict whether the patient is stroke patient, whether the patient will return back to the emergency department, whether the patient will go to the ICU within 72 hours. Okay. This is very briefly introduced model here. And the challenge of the model is need to integrate the vital sign and the clinical narrative. Actually, is the text data here, and to predict the outcome. Okay, the outcome including the ICU within 72 hours, and where the patient revisit the ED within the 72 hours. Okay, this is the outcome prediction task. Okay, so here we also develop the system, prototype system. Okay, so yeah, as you can see, the left-hand side, the PDF file will generate after patient dialogue with the doctor, and you can see the dashboard here, right? And the right-hand side, we use the similar technique using the large language model to provide the interface that help the patient or the doctor can dialogue with the large language model. Okay. Since we limit the content, so we can prevent the hallucination of the large language model. All right, the last one I quickly introduced, only one size, okay? The last one is adapt to the NLP in nursing, okay? This is very special culture in Taiwan. The lesson report usually in Taiwan is Mandarin Chinese, so it's very challenging. So in this task, we use the lesson report to predict whether the patient will have the delirium situation within 12 hours, and also to predict the mortality risk after hospital discharge. So it's very interesting to know that we fuse the clinical knowledge into the model. We call, in Chinese, we call 节气. We encode the 节气 information into the model, and the result demonstrate that the 节气 feature is very useful in the nursing field. Okay, let me conclude the talk. Okay, so the application of the NLP in clinical setting is beginning to show the promising results. And the large language model in the clinical is start to become better and better, and many applications we can see it in the clinical in the future. And the smaller, faster, and the more specific model is the future. Okay, That's my talk. Thank you for your listening.
Thank you. Is there any question from audience? Okay. No. I think the most important things for chair is close the conference on time. As Professor Zhang his great talk very clearly. Maybe if you have any question, maybe you can connect with Professor Zhang. On behalf of the National Defense Medical Center and the Tri-Service Hospital, I will
As we approach the end of today's sessions, we would like to invite Professor Chin Shen-Lin to deliver the closing remarks.
I think the time is limited. Maybe we have a good photo and then we finish the section. Okay? So maybe everyone come here, come to the left side, and then we have a good photo. Okay. Or we can just stand here. How do you think? 那到前面好了。We can sit here.
We thank all of you for attending today's symposium and express our gratitude to all speakers and participants. We look forward to future interactions and collaboration. Have a pleasant evening.